Exactly.
I'm so glad you rang my bill.
Yeah, my understanding is you have one more, so you're just kind of there.
The court decision.
And then, yes,
Call to order the House Committee on Health Care for this February 7th. And we have a lot of work to do today, and we're going to have all right, I'll try harder. You heard me open up the committee, and we're open for business. We have a bunch of work today. We're going to have to move the order around as it fits. We're going to have to be limiting the time of testimony. I can remind you all, I hope I get as many folks in to give public testimony as we possibly can. But I can remind you all, you can submit written testimony for the record in order to make clear we understand your opinions. I'm going to carry over House Bill 4005 to Friday. We intend to work it on Friday. It's our current hope, but we will not be talking about it today. It'll be carried over. Do I have? Where should we go? Should we go to the second bill?
Yeah, she's here. Sancheza's trying to get a quorum, so she's going to be in a couple minutes. Do you want to go? 8 a.m. on Friday. Sancheza's waiting for a quorum on her head, so she can't leave. Malstrom's bill. 4156.
So far, but that gun bill got carried over in.
You open a public hearing on House Bill 4156, is that? Yeah.
Yeah.
4156. Can you tell us about that bill, please?
Mr. Chair, Vice Chairs, members of the committee, before you is House Bill 4156, brought to you by Representatives Doherty, Malmstrom, and Kinnemer. The bill prohibits health insurers from removing prescription drugs from a formulary during a plan year with one exception, prevents health insurers from modifying consumer cost sharing for prescription drugs during a plan year unless a generic drug is added to the formulary, forbids health plans from enacting new utilization management controls on prescription drugs during a plan year. There is a -2 amendment which would require carriers in a geographic region that offer individual, small employer, and group health plans to offer at least 25% of plans with no deductible or other cost-sharing requirements except a flat dollar copayment. The -2 is on OLIS, and for folks listening and that are outside, we do have an overflow. It's hearing room C, so if you want, hearing room C has been open so you can monitor and observe the committee hearing.
Can you call the first panel, please? Or Representative Malmstrom first, is that right?
Yes.
Can we call Representative Malmstrom, please?
He's headed there.
And the on-deck panel is who are the next three going to be?
I'll grab that.
Thank you, Chair Greenlick and fellow members of the House Health Care Committee. For the record, my name is Representative Sherry Malmstrom. I represent House District 27, which is Beaverton and parts of Southwest Portland. As some of you may know, I'm also a survivor of childhood lymphoma. I am here today to discuss House Bill 4156, the Copay Transparency Bill, and encourage the committee to pass HB 4156 with the -2 amendments. For a cancer patient or other patients with expensive drug costs, buying a health plan that covers the drugs that they need at costs that they can afford has a direct impact on their ability to effectively fight and beat their disease. Even with health insurance, cancer can be very costly, especially if the patient has a plan that does not cover their drug or covers the drug at a cost that they cannot afford. HB 4156A will empower patients to easily find and compare drug coverage and cost information across available plans, making them better able to choose the coverage that fits their medications and affordability needs. The bill, with the -2 amendments, would require insurance carriers to disclose all drugs covered under each health benefit plan, including those drugs administered in a provider's office and typically covered under a PENS medical benefit as opposed to the prescription drug benefit. Additionally, HB 4156A would require health plans to disclose a dollar cost or dollar range a patient would pay if their drug is subject to a coinsurance, allowing the patient to adequately estimate monthly out-of-pocket costs. Studies have shown that cancer treatment medications are increasingly being placed on the highest tier of a formulary and being assigned a coinsurance. If the patient only knows their drug that they need will cost 30%, that does not give them the actual dollar cost and prohibits that patient from knowing if they'll be able to afford the dollar cost, if they should be able to buy that plan. This plan will make sure that patients have dollar cost information before they buy the plan. Finally, HB 4156A ensures an insurance carrier honors the contractual agreement entered upon during open enrollment. The legislation would prohibit a carrier making a change to the drug formulary during a plan year, except in the case of an alert issued by the Food and Drug Administration. Being treated for cancer is hard. Researching and purchasing a health plan which covers medication shouldn't be. As a child, my family was able to cover the cost of my care for my lymphoma. But sadly, too many families can't afford the cost of these out-of-pocket expenses for their care. And HB 4156A will provide transparency for consumers and help patients find the most affordable care that they can for their need. Thank you.
Are there any questions, Representative Malmstrom?
Wait, Representative Cameron, did you have your hand up?
Just a comment, if I could. I appreciate you letting me add my name as a sponsor, and appreciate you bringing this bill. I think transparency is an issue that we need to figure out how to manage, and this is, I think, a great step in that direction. Thank you.
Thank you.
Thank you very much. Can you call the next bill, please?
We have David Almeida, Christopher Friend, and Raylyn Stewart.
I'm going to ask you all to please try and be brief on both sides of the issue. We have two huge lists on other bills.
Good job, Sherry.
Go for it. Identify yourself.
Good afternoon, Chair Greenlick, Vice Chair Nose, and Vice Chair Hayden. My name is Raylyn Stewart, and I am from Portland. Thank you for having me here today. I am the Program and Outreach Manager for the Epilepsy Foundation Northwest, representing Oregon and Southwest Washington, and I have a daughter living with epilepsy. I come before the committee today on behalf of the nearly 45,000 people living with epilepsy in the state of Oregon to express our strong support of House Bill 4156, which would prevent insurers from making mid-year changes to the prescription drug coverage included in healthcare plans. People with epilepsy choose their insurance based on the coverage details provided at the time of enrollment and can be seriously harmed by a unilateral mid-year change in prescription drug coverage. 4 years ago, this happened to us, and for 7 months, I had to pay out of pocket over $2,400 a month for one prescription for my daughter's medication, which was controlling her seizures. Epilepsy is a medical condition that produces seizures affecting a variety of mental and physical functions. Nearly 3 million Americans live with epilepsy, and 1 in 26 Americans will develop epilepsy at some point in their lifetime. For the majority of them, epilepsy medications are the most common and most cost-effective treatment for controlling and/or reducing seizures, and they must have a meaningful and timely access to physician-directed care. Epilepsy medications are not interchangeable, and treatment of epilepsy is highly individualized. Patients often shop for their insurance and choose plans based on their individual needs, which can include prescription drug coverage. When health plans stop or change coverage for a particular medication mid-year, beneficiaries are left with higher out-of-pocket expenses or no coverage at all for necessary therapy. Health insurance companies are allowed to change the terms mid-contract, but consumers are locked into the plan and unable to make changes mid-year. Treatment for epilepsy is not a one-size-fits-all solution. Individuals who are currently stable on their medications are at great risk of preventable seizures and related complications if they are forced to use alternative therapies when their health plan stops or changes the coverage on their current medications. Medical professionals must have the ability to determine the most appropriate treatment available with the fewest side effects. Selection of the appropriate medication to prevent seizures is determined by a number of variables, including type of seizure, seizure frequency, age, gender, and other health conditions.
I'm going to ask you to wrap it up, please.
Yeah. We urge the committee to pass House Bill 4156 in order to prevent insurers from changing the terms of health plans as they relate to prescription drug coverage in the middle of the year.
My name is Christopher Friend. I'm the Oregon Government Relations Director for the American Cancer Society Cancer Action Network. Appreciate the opportunity to testify in front of you today. And I'll be speaking specifically to the -2 amendments of this bill. ACS CAN members see 4156 as a tangible way to empower patients to be smart consumers by allowing them to be comparative shoppers when searching for an insurance plan. Over the last few years, we've really relied on patients to be smarter consumers of the healthcare system, and this bill really empowers them to do that, to be smart shoppers. Frequently, cancer patients depend on cutting-edge therapies to sustain themselves. Even more frequently, oncology protocol depends on specialty drugs, which are subject to co-insurance. Simply knowing a percentage of a cost is prohibitive to a family that's trying to estimate their monthly budget to keep their child alive. We've got a real story of Grant and Becky Krim, ACS CAN members here in Oregon. Becky says, many of Grant's life-saving medications are specialty drugs, and all of his medications are subject to coinsurance. As a result, our family is responsible for 10 to 25% of coinsurance. Simply knowing a percentage of coinsurance doesn't help my family know how much we need to budget for Grant's medication. Being a working family, we do our best to estimate our monthly costs for Grant's medication, but despite our best efforts, we frequently miss the mark. This is the story that you hear from not just cancer patients, but for folks who rely on life-sustaining and life-saving medications every single day. They do their best to budget, but by hiding behind a formula, it makes it very, very, very difficult for patients and their families to make a monthly budget for their life-saving medications. At its core, House Bill 4156 is about consumer protection. It's about empowering patients to be smart consumers. It's about allowing comparative shopping. If you believe that Oregonians deserve to estimate their cost of medication no matter where they live or where they work or what their job is, I urge you to support House Bill 4156. If you believe Oregon's healthcare consumers should be protected from arbitrary and unexpected changes to the healthcare contract, I urge you to adopt and support the -2 amendments. Finally, I would just like to make one point. Health insurance is a contract of industry. Patients don't have the ability to negotiate that contract. Patients simply have a menu of contracts for which they get to make selections from. But they're locked into the terms of these agreements, and unfairly so in my opinion. When a drug is removed from the formulary, someone with cancer is dealing with a lot. They shouldn't have to deal with not having figure out how they're going to cover a cost of a medication that's no longer covered. If cancer patients are forced to be locked into a healthcare contract for a plan year, I think it's only fair that we ask the terms of the agreement remain the same for the insurance carrier. Thank you for the opportunity to testify today.
Thank you. We're going to turn on the 2-minute timer from now on today, and it's going to be up there. I've never used it before, so we may have some glitches to go. Are you ready?
2-minute warning? Very well.
Warning.
Let me sum up this. My name is Dave Almeida. I'm the Government Affairs Director for the Leukemia Lymphoma Society. I will sum up this issue very succinctly. Oh, good to have started. The issue is this. A drug may be FDA approved. A doctor may prescribe it. A pharmacy may stock it. But if a patient cannot afford it, all of that is meaningless. The rub here and the problem is that increasingly insurers are using a form of cost sharing called coinsurance. That requires the patient to pay a percentage of the total cost of the medication. In Oregon, for example, the average coinsurance in silver plans is 49%. That can equate to thousands of dollars per prescription per month for a patient. All right. Making this problem even worse is the growing prevalence of high deductible plans. In Oregon, the average combined deductible in 2017 is $2,822. So if a patient cannot pay $2,822, the drug is meaningless to the patient. Taken together, these benefit designs require patients to pay high upfront costs in order to access the treatments prescribed to them. When cost sharing becomes a barrier to access, patients do not use their medications appropriately. This bill remedies that problem by requiring of an insurance plan of a carrier that 25% of their plans utilize a copay-only cost-sharing structure in their entire prescription drug benefit plan. This will guarantee that patients have access at least to some health plans that do not involve the financial barriers associated with co-insurance. Let me sum it up like this. A copay is a flat fee, typically one that you may pay when you go to your primary care physician. That copay, that fee, is by and large very financially accessible to patients. It's $25, $35, maybe $100. Co-insurance, on the other hand, is not financially accessible to patients because it's thousands of dollars. So with that, Mr. Chairman, I will wrap up my comments and ask you and the committee to pass House Bill 4156. Thank you very much.
Thank you. Any questions, Pam? Thank you very much.
Whoops.
Where are we?
I have a question.
Go for it.
Thank you. I'm really sympathetic to this issue. I've heard from physicians in my district about this and their patients not being able to receive the treatments that they need. So I understand all of this. I do think a big part of the problem, though, are drug costs. So are all of you supportive of HB 4005, Representative Nose's bill?
So let me answer that question from the standpoint of the Leukemia Lymphoma Society. We are supportive of transparency, period, across the board. Drug pricing transparency relating to insurance plans across the entire health spectrum. Where we stand on drug pricing transparency is this. We believe that drug pricing transparency should be handled at the federal level, at the Department of Health and Human Services, so that one standard applies to all states as opposed to a patchwork quilt of different standards across the United States.
How about this issue? Should this be only a national issue? The bill in front of you? Would you argue this needs to be a national issue?
I think absolutely, Mr. Chairman. Here's the thing. There are plans, as you know, that are regulated by the state and plans that are regulated by the federal government. So this bill is intended to address plans regulated by the state, but certainly for plans regulated on the federal level, absolutely.
I'd like to answer the question. ACS Can is neutral on Representative Nose's bill. We're an evidence-based organization, and our evidence, we just don't have enough to be compelling to be supportive of Representative Nose's bill. What I will say is that there are many significant barriers to patient costs for medications. This, we know, is one that will help patients estimate their monthly costs and budget for them and select a plan that covers their drugs at a cost that they can afford. I'd like to make one last point. This bill is widely supported by patient advocacy groups and Healthcare for All Oregon. Patients are behind this. This is a consumer protection bill at heart. Thank you.
Let's try and stick to the bill at hand if we can. Would you call the next panel,
Ask her to
please?
do that.
We have Jessica Adamson, Abigail Stoddard, Elise Brown, and Vince Porter, and then on deck we'll have Scott Winkles and Felissa Higgins.
You're all under the 2-minute rule today. Let's see how fast you can talk.
Thank you, Mr. Chair, members of the committee. For the record, Jessica Adamson with Providence Health and Services. We are here, regrettably, in opposition to this bill. This bill is one that we have seen before and talked with the advocates about last session and urged them to reach out to us in an effort to try and work through some of these issues to find common ground. Alas, there was no effort to do that, and so we are here in opposition because this bill quite simply will add cost to the system. When drug prices increase at the rate that they do, and they are among the fastest growing costs in healthcare, we need to be able to use smart tools in formulary management to take drugs that are equally as effective and move them down the formulary and other drugs up the formulary in order to try and keep costs in control. This bill limits our ability to do that. It only allows us to adjust prices down, not up. And so when prices jump in the middle of the year, there is nothing we can do about that. And that will pass pass onto the premium, which makes premiums more expensive, which makes plans less accessible to individuals, particularly on the individual market. This is something that Providence is particularly sensitive to as the only statewide carrier on the exchange. We can tell you that we need to use every tool that we have to protect patients, to make sure that they have access to drugs and on every tier of the pharmacy ladder, but that we are able to move drugs within tiers mid-year in order to make sure that we can afford to offer those plans statewide. We ask you to not adopt the -2 amendment and not move this bill forward, but we commit to this committee and to the proponents that we will work with them in the interim to address many of their issues. Thank you.
Thank you. Good job.
Good afternoon, Mr. Chair and members of the committee. Elise Brown for America's Health Insurance Plans. AHIP is the National Trade Association of Health Plans across the country. And I want to take my time to just address the transparency issue that everybody is buzzing about. Let me do that. Health plan formularies are transparent. Drug prices are not. Federal regulations require health plans to publish up-to-date, accurate, complete list of all covered drugs on their formulary. Health plans also have to include tiering structures and/or any restrictions they use, such as prior auth, such as step therapy, in a manner that is easily accessible to enrollees, prospective enrollees, to the state and to the general public. So I wanted to use that time to make that clarification. There seemed to be some question as to whether or not any of this information was transparent, and I just wanted to assure you that it is. I'll yield the rest of my time.
Thank you, Mr. Chair, members of the committee. My name is Abby Stoddard. I'm a pharmacist with Prime Therapeutics. Prime Therapeutics is a pharmacy benefits manager. We manage pharmacy benefits for health plans in Oregon and employer groups in Oregon. I want to use my time today to respectfully oppose this bill, but I want to be very clear that we share the intent with the sponsor of making sure that members who need their drugs get their drugs and are able to afford it when they get them. We are committed to talking all day long in the interim about how that process happens, what members know, what providers know, what that process looks like, making that process better. However, the formulary has to change because the drug market changes and drug prices change. Example I want to make sure the committee is aware of to illustrate this point is the drug Humira. It's one of the #1 best-selling drugs in the U.S., if not in the world. When it launched in 2004, it was about $13,000 a year. Now it's over $50,000 a year. So to the sponsor's point, you can have a member in a coinsurance plan, and that coinsurance can never change. But the reason why they're having trouble budgeting their health care costs is because the price of the drug has increased nearly 6 times in the time they've been taking it. It hasn't gotten any better. Their disease hasn't gotten any better. The drug has just gotten more expensive. Formularies and formulary changes is our ability to hold these manufacturers accountable so that when they get a competitor, we can tell them that the price gouging stops. We can tell them to offer us a better price or we're going to go with somebody else. And when that change needs to happen, again, we can talk at length about protections in place for consumers when that happens. The last thing I want to just mention on this bill is that I want this committee to be very aware of what this does to opioids as well. We have had plan sponsors in the last year, of course, be very concerned, remove opioids from formulary, put prior authorization in place because these drugs are dangerous. And when they want to do that, they want to do that now. They don't want to wait.
Thank you very much.
Yeah.
Any question? Yes.
I have a question, and this could go for any.
2 minutes on us. Too.
Okay, good. I'll try to talk really fast. And this could go for this panel or anyone else that follows after. I think this has been done in other states. And I'm wondering if anyone on this panel or others can tell me what savings may have come to consumers as a result of this, or what added costs may have come to insurers. I think one of the other things, clearly we're trying to protect consumers from the volatility of pharmaceuticals as we are trying to keep control of those costs. So it's a clear benefit. I get that for insurance that might add a little bit to your volatility. So my second question is to whether the reinsurance pool that we've just created, is this something that insurers could tap into the reinsurance pool for unexpected costs? And then thirdly, like when you say you want to come back to the table and you've got ideas of how to improve this, I just wonder if you could highlight without detail what some of those ideas might be.
Absolutely. Mr. Chair, Madam Representative, thank you for that question. In terms of other states looking at this piece of legislation, I can tell you the state of Washington looked at a nearly identical piece in the last session, and I believe the fiscal note to their state employee plan was about $9 million a year. I'm from Minnesota. My state of Minnesota has looked at this. The cost to our state Medicaid was about $6 million a year. But I want to be very clear. Health plans take into account the whole picture when we look at costs. If a drug is something like the hepatitis C drugs, for example, those drugs were blockbusters in cost when they came out, $84,000 a treatment, but we paid for them because they worked, and they were cheaper than liver transplants for a lot of folks. So we take into account the big picture. We know a large talking point is, cost savings. Are we going to realize that down the road? And at the price these drugs currently are, it's simply not there. It is not improving anyone's outcome. It's just the cost. And to your last part of your question about making the process better, Minnesota mandated, I believe 2 or 3 years ago, that we make the exception process electronic, and everybody has to use it online. And that step itself has been huge for us. We can get exceptions turned around faster, easier. No one's sitting on hold on the telephone. Minnesota did that. New York did that as well, I believe. Other states are looking at it. It's called electronic prior authorization. That's one of the tools that we love to use to make this better, and we would be happy to look at that here. And I don't have an answer for the reinsurance part.
Yes.
Let's move on.
Okay. You can follow up with me later, too.
I will. Thank you.
Call the next panel, please.
We have Felicia Higgins and Scott Winkles, the last two.
We are planning on working this bill today. We'll carry it forward.
Chair Greenlick, members of the committee, for the record, my name is Felicia Higgins. I'm the political director at SCIU Local 49. And I'm here today representing SCIU. We just got the...
Oh, that mic.
Do you want some water? A little bit. It won't help. This is it. This is as good as it gets. I'm here today representing SCIU Local 49, SCIU Local 503. Looking at the original bill, we had some concerns regarding the impact on the Public Employee Benefit Plan, as well as our rights to collectively bargain changes to drug formularies mid-contract, which in some cases we do bargain over our benefit design, especially in some of our hospitals where there may be plans where we can get cheaper drugs by pooling our membership plans with the hospital's purchasing plans. And so therefore we might want to change the formulary. We wholeheartedly support the proponents of this bill's intent. We would go farther than the bills that you have in front of you and actually cap drug costs and make sure that people were forced to pay a certain amount and have no copays and deductibles. That's not what is. With some small changes to this bill, we feel like we could move to support it, and we'd like to work with the proponents to make those changes. Thank you.
Chair Greenlick, members of the committee, Scott Winkles representing the League of Oregon Cities. Cities in Oregon are primarily self-insured, either through city county insurance services or as individual employers, and they contract with the prescription, the benefits managers, and we've identified some concerns with the bill. The first is the issue is we couldn't change the price unless a generic category A were to come on the market. In the case of the hepatitis C drug that you heard testimony on earlier, when its competitor came on the market, even though that was a brand name drug, it introduced competition and was pro-consumer, and also it worked. So being able to vector consumers onto the less expensive, just as effective drug is an important consumer protection. Additionally, the language that requires that we wait for an FDA notice on a drug, we believe could potentially hamper the ability of the pharmacy benefits manager to pull a drug where they have indication that there's a risk. My understanding is this is what happened with, I believe it was Vioxx, one of the pain drugs, where the benefits manager pulled the drug from consideration prior to the FDA warning because of some negative feedback. We do look forward to working with proponents on this bill to address some concerns and having those conversations whenever they wish to be held.
Scott, does this bill affect self-insured plans?
Sir, our reading of the bill is it would we contract with Express Scripts or with another formulary, and it would change that. Our insurance and analysts
I assume it's only regulated plans, is that?
Portland several cities identified this as a challenge to them.
Huh. We'll find out.
Because they contract. I mean, they contract with the formulary, so we would use them.
But,
We'll check.
okay, we should look into that, because
Yeah.
that doesn't seem right to me.
Thank you very much.
Thanks.
We have one person who would like to testify.
Rebecca Roth.
Your self-insured plan, which most
And then we're going to
cities
close the
and
public hearing.
most universities are, the state is, like, you're not regulated that.
Rebecca Roth, Sylma, Oregon, and Chair. I'm here because I was listening in the other overflow room and just wanted to testify because I heard that patients are really for this. I'm a potential patient. All of us in this room are potential patients, and all of us benefit from a system where there's not too much demand on the system. And so what socialism does is put too much demand on the system, and eventually the system collapses. And so like in England right now, they're having a healthcare crisis because they've been promising too much for too long, and everything is collapsing. Once it collapses, nobody gets anything. I just read recently of a dentist who went over to England to do a little bit of dental care. He had 300 people at his door for the weekend to wanting dental care because there's no dental care available. When there's a socialist promise that everybody gets everything they can dream of, and all of us have to pay for that, eventually we all go bankrupt. And so the net effect of it is that we all end up with no health care at all.
Thank you very much. I'll close the public hearing.
I remember, she's testified in those a few times.
Which bill? We're here right now. 4150.
She was on the wrong bill.
On 4150. Close the public hearing on 4156.
Maybe not.
And carry the bill over till Friday. You add that to the carryover. Open up the public hearing on House Bill 4137.
Mr. Chair.
What do we have?
Mr. Chair, Vice Chairs, members of the committee, before you is House Bill 4137, brought to you by Representative Sanchez. The bill requires the Alcohol and Drug Policy Commission to provide the Legislative Assembly a comprehensive report and recommendations no later than September 15th of this year, requires Commission review and update the addiction prevention, treatment, and recovery plan annually, and grants the governor the ability to appoint a director of the Commission. There is a -1 amendment. It is on OLIS. It does a number of changes, which I'm sure will be walked through momentarily. Representative Sanchez. There's a no revenue impact, but there is a fiscal impact to the -1. The impact statements are on OLIS. Has a subsequent referral to Ways and Means.
Welcome.
Thank you. Sorry for the delay. Chair Greenlick, members of the committee, I'm Tana Sanchez. I'm State Representative for House District 43, and I am here today about House Bill 4137. Yes, there are a few changes to it. Essentially, let me just say, I'm not all about the statistics and the numbers. These folks will give you all of that. Essentially, what I'm really hoping for is that we're submitting a bill that will ask the Alcohol and Drug Policy Committee to actually do their job.
Reasonable request.
It seems like a reasonable request. The Policy Commission has been in existence for 9, almost 10 years, and they have yet to submit a strategic plan, a report of any kind, and we're just very concerned that that needs to happen. We are all very, very clear throughout the state, I think, that we have a significant issue with addictions. We have a significant issue with mental health services related to addictions. We have a lot of people who are homeless who are suffering from addictions. We have a lot of people in our child welfare system because of addictions. We have a lot of people in our criminal justice system because of addictions. We have a significant issue in this state and throughout this country, I think, with regard to addictions, a lack of treatment, a lack of recovery services, just a complete lack. And I think that it is really, really important for that commission to actually come up with a report and a plan for how we deal with this. So essentially the changes in the bill are that simply that date, put a date on it, and let's make it happen.
Great.
Chair Greenlick, committee members, my name is Mike Marshall, and I have the honor and privilege of serving as director of Oregon Recovers, a statewide coalition of people in recovery, treatment providers, and the drug and alcohol counselor and peers around the state. Our mission is to transform Oregon's fractured and incomplete addiction recovery system into a recovery-based continuum of care which recognizes addiction as a chronic disease requiring a lifetime of support. It's really simple. I'm also a person in long-term recovery, which means for me that I haven't had a drink or drug in over 10 years. I'm here with a number of people who are also in recovery, and I'd like to take a moment, with the indulgence of the chair, to ask them to stand and be recognized.
Please do. We don't usually applaud, but we'll nod our... Thank you very much for being here.
These tremendous folks got into recovery, got sober, staying sober despite the system, not because of the system. And I really, really want to emphasize that. Oregon Recovers applauds Representative Sanchez for authoring this small but critically important piece of legislation. House Bill 4137-1 may appear to simply add one word to the title of a future document and set just two deadlines for work that is already required to be completed. This bill is, in fact, the tip of a larger strategy to transform Oregon's addiction recovery system. It is a strategy devised by a consensus of key stakeholders outside of government who are on the front lines of the addiction epidemic in Oregon. It is a simple strategy. We simply need a plan. We need a plan that answers two fundamental questions. How do we dramatically reduce the addiction rates in Oregon, which are some of the highest in the country? And how do we get more people suffering from addiction into recovery? Two simple questions. 10 years ago, as Representative Sanchez pointed out, the Oregon legislature created the Alcohol and Drug Policy Commission and charged it with answering these two questions by developing an integrated plan for prevention, intervention, ideally treatment on demand, and recovery support. The Oregon Recovers believes the ADPC is potentially a powerful vehicle for advancing the transformation of the state's addiction recovery needs. Today, you will hear from a powerful and unified set of voices in support of this legislation. You'll hear from a mom who had to go out of state to find recovery for her son. You'll hear from an addiction doctor at Kaiser Permanente about the challenges of treating his patients in the current fractured system. And you're going to hear from the treatment providers, leaders of the recovery community, as well as the drug and alcohol counselors who are coming together within Oregon Recovers and around this legislation in a manner that they have never done before in the public policy arena. I do want to caution that although no one, I believe, has signed up today to speak in opposition, there are indeed voices of opposition to the strategy behind HB 4137. There are those who continue to believe that addiction is a moral failing, not a disease, and hence the best strategy is to rely on the criminal justice system. Given that Oregon has the third highest youth incarceration rates in the country, and that 75% of the young men at McLaren admit that they were drunk or high when they committed the disease they are serving time for, I'd say that that is a proven failed strategy. And there are those who believe we are trying to move too far, too fast, but that the ADPC can't possibly produce a plan by September 15th of this year. I'd respond to that by pointing out that on average, we lose 4 to 5 Oregonians each day to alcohol-related or drug-related deaths. We don't have the luxury of time anymore. It's been 10 years, as Representative Sanchez says. We're asking to get going. But I also want to point out that we are pushing hard for progress, not perfection. If the ADPC issues a document by September 15th of this year that simply provides a framework for a detailed strategic plan, a 2019 strategic plan, a framework that addresses prevention, intervention, treatment on demand, and recovery support, Oregon Recovers will celebrate that success.
Please wrap it up.
I will end where I started. This is a small bill with big ambition. If implemented, it will save lives and lift up families across Oregon. Oregon Recovers thanks Representative Sanchez and urges a yes vote on HB 4137-1.
Thank you. Hi, Chair Greenlick and members of the committee. Thank you for having me today. My name is Allison Mann, and I'm not here with a title or a role in the treatment profession. I'm simply just a mom. My reason for being at this table today is my life changed the summer of 2015 as my son's disease spiraled out of control. A healthcare crisis I couldn't call 911 for. With insurmountable fear that my child would die at the hands of his addiction, we began the desperate search for a program to help him. Sadly, that's when our nightmare became even worse. With each and every call, my frustration and desperation grew. There are lots of compassion from people caring about us and helping us to find a roadmap to move forward. But no one had that. There were county mental health and juvenile professionals who tried desperately to communicate their concern. There were local law enforcement officers who stood as I cried and shared my sorrow and wanted something better for my son. There were school counselors and administrators ready to give me a hug, wanting nothing more than for me to find a solution for saving my son. Simply put, Oregon has very few options for adolescents. Not one provider had a safe, secure facility where I could take my son for medical treatment he desperately needed. And those where he might have found services were not part of a continuum of care with FSE data I could trust, as a mother fearful for her son's life. In the end, our story boiled down to luck. If it was not for a mental health professional pointing us to a potential solution outside of Oregon, that I began to have hope that my son might live. As a family, we got lucky, but the luck involved liquidating all of our assets, including selling our home, so we could send our son to the other side of the country to start his recovery journey. After 3 months in a program in Georgia, the equivalent to a therapeutic emergency room, we moved him to Arizona for long-term care, where he could finish high school with an evidence-based continuum of care. The bottom line is this: that solution doesn't exist in Oregon. It shouldn't be that difficult, expensive to access life-saving medical care. We must transform the current fractured and incomplete system into a recovery-based continuum of care that recognizes addiction as a chronic health condition requiring a lifetime of attention. Thank you for hearing me today. I urge you to vote yes on HB 4137-1. Thank you.
Applaud.
Thank you.
Thank you for sharing your story, though.
Question.
Appreciate it.
Oh, sorry.
Did you
Questions?
have a question?
Yeah, please. Thank you. Thanks, Chair Greenlee. Mike, I was surprised earlier this summer when I met with you and Oregon Recovers that around 80% of the meetings of the commission never occurred over the last 2 years at the time of a national epidemic, thousands dying. Why would that be?
I was not a member of the commission. I can't speak to that. What I can tell you is since that time, the commission has a new executive director, a new chair, and has been meeting much more regularly and focused on this. We get that this has not been the right operation in the past, but it is the best operation. Instead of going out and reinventing the wheel, Oregon Recovers, and I think all of our coalition partners and Representative Sanchez recognize we've got on paper one of the strongest commissions in the state that has the capacity to fix this. And so we're putting all of our effort into making them as effective as possible.
And then just one more question.
Very briefly.
And why do we need this commission and also a opioid task force? It seems like a duplication of resources. Can we combine those two efforts?
I don't know the answer to that question, but that would seem logical, wouldn't it?
I would say absolutely yes.
Overlap after we get so long, an underlap.
Thank you, Mr. Chair. I was on that commission. We often didn't make quorum. That is why I was frustrated by it, and I do have hopes for the one going forward. I do think it's great that the governor has now reassigned her liaison from the public safety liaison to the healthcare. I think that's a huge fundamental shift. I very much support this bill, just added my name to it. Really want to thank everyone who's here. We need to keep the pressure on to keep this moving. And I just wondered if everyone could stand up really quickly again, because I missed it picture. No? Here, just really quickly. Sorry, I'm going to incur the wrath of the chair. Thank you.
The chair.
All right. Sorry for the disruption.
Yes.
Thank you.
Thank you.
Oh, sorry. May I just for a moment? Representative Sanchez, has the executive director weighed in favor of this deadline that you've put in the bill?
Actually, no. Unfortunately, they're asking for more time. And I understand that. I understand, thinking that you don't have, a lot of things together. He started his position in July. And by the time we request for this, some preliminary report to be finished, he will have been there for 1 year and 2 months. I personally think that's enough time. There may need to be other bodies in the room. That's where the fiscal comes in. I think the fiscal is significantly higher than we had anticipated, and we'd been asking for that fiscal for some time. So there are struggles, yes. But I think we need to move forward. And, and I've talked to them myself. I've gone to the commission meeting and said, all I'm asking you to do is do your job, and I'm pushing you to do it. That's really all we're trying to get to.
Mr. Chair, I have to say, this is the kind of thing that just drives me nuts. We've been dealing with a commission now that we've been spending money on for apparently a long, long time, and we've got nothing to show for it. I appreciate your being willing to push us to get something done. So thank you.
An annual budget of $350,000.
Oh, my heavens.
Would you call,
Luckily, the governor's putting some.
Dr. Anderson, are you ready?
Yep.
Thank you.
Yeah.
Dr. Anderson, John Eames, Eric Martin, and Brent Canole with Alano Club.
Dr. Anderson's also a great flautist, if I remember correctly.
A great what?
Flautist. Play the flute?
Nope.
Wrong one.
I don't know. I've never tried. Maybe I am. Okay.
Please go ahead.
So, Chair Greenlick and members of the committee, thank you so much for this opportunity to speak in support of this bill. My name is Brad Anderson. I'm a board-certified addiction medicine physician, and since 1995, I've had the privilege of being the chief of the Department of Addiction Medicine for Northwest Permanente, the medical group for Kaiser Permanente. I've treated thousands of patients with addiction in outpatient, inpatient, and residential settings, and I can guarantee you I did not dedicate my medical career to something that is not a medical disease. We all know the opioid and addiction crisis requires urgent action on many fronts. This bill provides an important part of the solution: accountability for the development of a comprehensive addiction prevention, treatment, and recovery plan for Oregon. A coherent state strategy is equally important for Kaiser Permanente as it is to providers who are exclusively funded by the Oregon Health Plan. Health plan coverage comes and goes, but we need to take care of Oregonians. As a physician leader working on the front lines of this public health crisis, I see the devastating impact on people's lives each day. On the darkest of days, we make the call that all parents fear, or we get the call that all doctors fear. If we truly believe addiction is at the same level as cancer or heart disease, and that people with addiction are as valuable as us or as good as us, we wouldn't let this happen. We must establish a system that fully recognizes it as a chronic disease that provides a coherent and adequately funded continuum of care. We know it works. We know medication-assisted treatment works. We have to remove barriers to that. There's been too many barriers for too long. Ironically, I am seeking I've applied for the Alcohol and Drug Policy Commission, so I want to get in there and do that. So I'm supporting this bill, and I want to get it there and fix that. So thank you for your time.
Thank you.
Oregon needs this. Oregon lives depend on this, especially young Oregon lives.
Thank you. Yes, go ahead. Whoever's next.
Hi, I'm Eric Martin, and I'm with the Addiction Counselor Certification Board of Oregon, and we certify addiction workers in the state of Oregon that work in addiction programs and peer programs. We have about 5,000 certified members and registrants, and our organization fully supports this House bill, and I myself served on the Governor's Council on Substance Abuse Programs 10 years ago, and it was the Governor's Council that basically folded and was replaced by the Alcohol and Drug Policy Commission. And when I was on the Governor's Council, we produced an annual report. That was our main function, was to produce this annual report with data analysis and a strategic plan. And we produced it annually every year. But since then, the Alcohol and Drug Policy Commission has not done that. So this is a really important bill, and like the others said, all it does is put a date. It just puts a date out there to say this is when the product is due. Thank you.
Chair Greenlick, committee members, thank you for allowing me to testify today, and thank you, Representative Sanchez, for your leadership on this important issue. My name is Brent Canode. I'm a person in long-term recovery for over 13 years. I say that just to make it clear that we do recover, and that's especially true when we have access to the services that we need and deserve. In my day job, I work as the director of the Alano Club of Portland, Oregon's largest recovery support center, and I also serve on the Oregon Alcohol and Drug Policy Commission, although I'm not testifying on behalf of the commission today. Additionally, I'm the co-founder of the Oregon Recovery High School Initiative, an effort to open Oregon's first high school option for students impacted by addiction in 2019, and I'm the chair and co-founder of Oregon Recovers, an inclusive statewide coalition comprised of people in recovery and their friends, family, and allies uniting to advocate for transformation of Oregon's fractured addiction recovery system. Representatives, as a recovery community, we are tired of burying friends and loved ones. And we're also exhausted from too many funerals and memorial services. And we're quite frankly angry at the lack of urgency over the past decade from our elected leaders and policymakers in the face of so much death and loss. But today we're also hopeful because in House Bill 4137 we see a light at the end of a very dark tunnel and a much needed course correction on addiction that is long overdue. I strongly encourage you to pass House Bill 4137. I suspect you're going to hear a lot about the opioid epidemic this session, and rightfully so. But let me be clear, we don't simply have an opioid epidemic, we have an unprecedented addiction pandemic which demands a comprehensive plan and a robust continuum of care that captures the full spectrum of this crisis, opiates, alcohol, and all. In my work, I have the privilege of watching people escape from the clutches of addiction every day. And at the same time, my heart is often heavy as I watch far too many of them fall and stumble along the way because they don't have support, and our system is fractured, under-resourced, outdated, and frankly, in many communities, it doesn't even exist. By empowering the ADPC to produce a comprehensive plan by a statutorily prescribed deadline, one that treats addiction as a chronic disease that requires a continuum of care, we will eliminate many of the barriers to recovery in Oregon. Thank you for your time today.
Thank you. I'm going to close the public hearing on House Bill 4137 and carry over House Bill 4137 to Friday. We'll see more on that. I'm going to open a public hearing on House Bill 4018. It's my intention to, if you check on OLS, there's a very large number of amendments to this bill on OLS, and we're going to find a way to work it where we can deal with whatever amendments we have in front of us. My intention today is to open up the public hearing and essentially deal with the bill in its current form. Although if you want to make a brief comment in your time period when you're testifying about one or the other of the amendments, that's fine to do. I'm going to kick off the hearing. In this case, I'm going to do it from here. And who will be the first panel after I speak briefly?
Mr. Chair, we have Jesse O'Brien, Bruce Thompson, and Mike Huntington.
You might join me by joining me over there. I just want to offer to the committee an opening on House Bill 4018. This bill is in aid of helping the legislature put some boundaries around the next round of the CCO movement. The CCOs serve nearly 1 million Medicaid members in Oregon. They've been working on a 5-year contract. That contract's been extended for a year, but we will be renegotiating those contracts again sometime during 2018 or perhaps early. I think we'll be intending to start them in 2019. This bill has 4 main elements that differentiate how CCOs should work over the next 5-year period. The first element in the bill is a requirement that in the future the CCO's governance boards will operating according to the public meeting laws in the state of Oregon. The second element to the bill, I think many of you who are interested in this have seen, talks about how the reserves of the CCO should be defined, minimum reserves, and directs that the remainder of those reserves be used to deal with improvements in the health of the community, social determinants of health, disparities, and things of that nature. The third element of the bill takes away a statement in the current statute that the state cannot serve a single statewide CCO. I was never sure in that whether it meant the state could do two statewide CCOs but not one, or could do one along with the local CCOs. But in my mind, that wasn't clear, and I think we ought to leave room to the state among its options to have a single statewide or two statewide CCOs along with the current regional form. And the fourth element of the bill takes away a requirement from the current statute that the majority of the governing board of a CCO be composed of the risk-bearing partners in the CCO formulation. It would allow each community to determine the nature of the board, but would require at least one member on the board of being a representative of the risk-bearing community. As I say, there are, I think we're up to what number? 15 or 16 amendments proposed. We're not sure where they all are. So we're going to hold this public hearing fairly briefly, and then move to a way to begin to deal with those amendments in a semi-rational way, at least as rational as we ever get. So, if the panel would, that's all I have to say. I'll be happy to answer questions. We'll save them until we get into debating the bill.
We need Bruce Thompson and Mike Huntington, please join Jesse O'Brien.
Jesse, why don't you start?
All right. Good afternoon, Chair Greenlick and members of the committee. For the record, I'm Jesse O'Brien. I'm the policy director with OSPERG, the statewide consumer advocacy group. I'll be very brief. We support this bill. We think it's an important but admittedly small next step toward fulfilling the goals of Oregon's coordinated care model. In particular, we think creating more openness and accountability in CCO governance is important to ensure that the public can access places where critical decisions are being made about the use of public dollars. We think it's really something like the least we could ask. We also think it's important to safeguard taxpayer dollars to by making sure that CCO funds are spent where they should be spent, on improving the health of Oregonians, and this bill takes some steps in that direction. We also think it's a positive step to change the definition of who is on a CCO board that in a way that would enable broader community representation, so more voices could be at the table than would be actually allowed under current law. And I haven't had the chance to look at all of the amendments. I've skimmed some of them. It seems like there's a lot of good ideas in there, but we strongly support the base bill, and we're happy to work with you moving forward on this.
Thank you.
Thank you. I'm Bruce Thompson. I'm here to speak in favor of House Bill 4018. I have not read, I have not seen the amendments that Chair Greenlick refers to. I look forward to those. I'm a family physician trained at OHSU for 7 years. I was in private practice with 4 other family physicians in my community for 20 years. Doctoring was my second career, as it followed a 14-year scientific research career at Oregon State University. I should also add that for the past 18 years, I have served as a county health officer through our public health system. Addressing social determinants of health and health equity are a key part of our public health department work. As an example, in 2000, our community was the second in the nation to ban smoking in all workplaces, including bars and taverns, and that was because of our work through public health. More recently, our health department has played a major role in developing the CCO's Community Health Improvement Plan. And I should note that I am here on my own time, and I am not in any official capacity speaking other than my own time. Several years ago, I attended community listening and work sessions to envision what a community-based healthcare system might look like. As the Affordable Care Act began, Oregon stepped forward forward with a plan that allowed the state to receive billions of federal dollars to provide health care coverage to our most vulnerable population. I don't need to tell you that. I need to remind myself that this is where we started. In the busy, hurried process of setting up the contracts for the CCOs, decisions were made about governance. The CCOs became the default fiduciary agent based on having certain contractual rights over financial matters. Essentially, the CCO became a private insurance company with proprietary rights over the financial management of public money. This is a very closed form of governance. In the time since the CCOs first stood up, much has been learned about their functioning, their successes, and their shortcomings. I've had the opportunity to study audits from the early days of CCOs and was surprised to learn that each CCO audit was formatted differently. It was hard to draw comparisons between and among the CCOs regarding financial statements. In addition, it was evident that each CCO had differing emphasis on the extent to which specific services were funded. Funding for addressing health disparities and social determinants of health was not clearly apparent. HB 4018 will address this problematic area by requiring compliance with the CCO's Community Health Improvement Plan. I'll finish. After 4 years of operation, it is clear that CCOs across the state vary widely in their acceptance of community input. I personally know of 2 members of our Citizen Advisory Council who resigned after several years of service due to the lack of cooperation they were seeing from our CCO in addressing the issues raised by the CAC. Clearly, these members were engaged in the process, but it was impossible to understand how that engagement was handled by the CCO. 4018 will address this problem by requiring Oregon's public meeting laws to be followed. Thank you for this opportunity to speak.
Thank you very much.
Chair Greenlee, members of the committee, thank you for the opportunity to testify in support of HB 40818. My name is Michael Huntington, a retired radiation oncologist from Corvallis. I am supporting HB 4018 because I feel CCOs can be the core of a strong universal healthcare system in Oregon, but only if they allow and encourage public participation and oversight as is outlined by HB 4018. As you well know, the Oregon Health Policy Board in its 2016 listening sessions around the state found communities wanting governance structures to reflect local community and public needs and to be transparent and accountable. They also said that the CCOs must invest savings to meet needed community services, implying to me that either these investments were not evident or were not sufficient. I have been turned away at the door of the Intercommunity Health Network board meeting and been reminded several times that these are meetings of a private corporation. I am acutely aware that such private meetings and the absence of public meeting rules allowed another CCO to commit what I consider gross misuse of public money, tens of millions of dollars that could have been used for patient care but were instead distributed to stockholders. HB 4018 will improve administrative transparency of CCOs and limit private use of public funds. These are important steps not only for Oregon's Medicaid program, but for public employees who we hope will trust and want to be part of the state CCOs. Such trust is likely to occur only if there is adequate transparency and public participation in the management of CCOs. Thank you.
Very much. We have one person that signed up in opposition. Why don't we call him now? Oh, I'm sorry. Yes. Go ahead.
Thank you, Chair Greenlee. Just one question. You mentioned tens of millions of dollars being misspent. Would you support not allowing these coordinated organizations not to put hundreds of millions of dollars into campaigns?
I would go back to what happened at that CCO. It's all legal, what they did. People were asked to invest money in a project that was being put together very rapidly. It was risky, and I honor that, and they should get return, but not the kind of return they got. And public oversight is necessary to prevent that kind of thing.
That wasn't the question. The question was, should they continue to put significant dollars that come exclusively from state or federal tax funds into campaign funds? Because that's a much bigger dollar figure.
I don't think I'm qualified to answer that one. I answered what I thought I could answer.
Thank you.
You know my answer to that.
Maybe Jesse, could you answer that question?
Could we call the next panel, please?
Jesse could answer it because
We have Courtney.
I could provide my opinion. I'm not sure how much.
I'm sorry?
He had an opinion. Can he finish?
Sure.
Chair Greenlick, Vice Chair Hayden, Osberg also works on campaign finance reform issues, and we're, in general, very concerned about corporate money being spent in campaigns, and we would certainly support anything that limited that, including with regard to CCOs. I mean, I think there is reason to be concerned about that. I'm not certain whether this bill is the vehicle to address those issues, but we are actually working on a bill this session to try to create a small donor matching fund that I hope would help lessen the impact of this. But we'll stick to the topic at hand. Thank you.
We have the next two.
We have Courtney Johnson and Josh Ballack, and then on deck we have Jeremiah Rigsby, Charlie Swanson, and Felicia Higgins.
We've got a bunch of people who want to testify in the next bill, so
I'll be very quick.
Appreciate that.
For the record, Courtney Johnston, I'm here today representing Coalition for a Healthy Oregon. That is 7 of the 15 CCOs right now.
That's right.
And I'm here today to testify on this. Coho, I'm not going to go into the things I like about this bill. I'm just going to touch on some of the concerns we have. Coho has 2 concerns about the base bill. We have concerns about the impact of removing the prohibition on a statewide CCO. I'm going to let my colleagues speak to that. I'm going to speak to the second concern, which is with the public meetings piece. We continue to oppose unprecedented action of applying public meeting laws to a private entity. We are very concerned about the impacts of putting these risk-bearing entities under statutes intended for public bodies. I want to be clear, Coho is not opposed to increasing transparency, but we are concerned about the ways in which the statute could discourage innovation and community collaboration. As you know, CCOs are community coordinators. We connect healthcare with education, public safety, human services locally in our communities, and we fear that if board members are out at a community event or having any kind of conversation with anyone in their communities that could constitute business, that it would discourage that kind of community collaboration that was important to the CCO model. We don't want to impede our ability to make connections and discuss innovative solutions across our communities merely because we fear compliance. So we'd like to ask to look at other ways to improve transparency. And I just really quickly want to say that I think we hear a lot about wanting to better understand how CCOs are investing their money, and COA believes that information you're looking to achieve that goal is already something we submit to the state. And we think that would improve transparency. It's already publicly available. The problem is it's not publicly legible. And I think if we should, to kind of reach the goals you have about transparency in this process, I think we could be looking at making that data easier to understand, easier to look at across CCOs, and that's what I think would be a good conversation to have here around transparency. Thank you for your time.
Thank you.
Chair Greenlick, members of the committee, Josh Ballack, All Care Health. I think we all agree that the coordinated care model has actually resulted in a lot of very, very good outcomes. Since I was there when you guys were putting it all together, and part of that, we've seen immense successes. But I think one thing that I've learned as I've left the legislature and moved down south to All Care is that really the secret sauce of the CCO model really is that locally based care. And I think it really does is, I was talking to my board chair today, it creates a sense of local pride for that CCO. We've seen incentivizes community development, basically the investment inside of the social determinants of health. That's not mandated anywhere inside of the current law, yet every CCO is doing it at one level or another. Could we do a little better? Could we do a little bit more broad? Abso-freaking-lutely. We can, but it's happening because of that local community investment. And also it increases partnerships inside of the community. So I think one of the things that we have a very strong concern around is having a statewide CCO. First and foremost, what happens is that if you have a statewide CCO, that centralization makes it possible for people to slip through the cracks, our Oregon Health Plan members. By having it locally based, it makes it harder because you actually have one point of contact that you can drive to, that you can see, that it's much closer. The other side is just simply a financial side of things, where you open the door for a large CCO to come in, purchase up other smaller CCOs, basically create a monopoly by undercutting the market and then jacking the rates up. This is something that we've seen time and time in many states and actually is currently going on inside of Central California through different types of things. We don't want to open that door. It's a place that we've gone before, and we don't really want to go back down again. So we do have concerns around the open meetings laws, but I thought my associate did a very good job of making those concerns known. And with that, I'm going to drive back to Grants Pass. Thank you.
Yeah, thank you, Chair Greenlake. Can you give me an idea of how much COHO members all care are spending on social determinants of health annually?
So I can tell you that depending on what your definition of social determinants of health are, our community investment dollars last year, I believe, was $1.4 million on top of $500,000 that we gave to the community advisory councils. We have 3 community advisory councils and divvy them up amongst that regionally or population-wise. So about 1.9, and if you look previously, we had a little bit of a dip in 16 and then went back. We were very, very high in 15.
And how about
Chair Greenlake, Representative Buehler, I couldn't give you that answer, but I could try to get an answer for you at a later time.
And Representative Buehler, I do want to make it clear, that's just community investments. That doesn't include a lot of the other wraparound things that we end up doing, like paying for PCPCH, working with other clinics to be able to expand access for integrated care, sometimes just local donations to be able to make sure that a baseball game goes off okay. I mean, that's just for community development. So I want to make sure that that's clear.
Yeah. Yeah, if you could get that data to me, I'd appreciate it.
You can share it with all of us. That'd be handy.
Well, does it? Do we know what else is defined under that? I think I might have some questions about how you would define that to look into.
That's some of the problem.
Right.
Yeah. Again, some people may think a baseball game is a social determinant. Some may not.
Well, I can tell you this much, as a diehard Chicago Cubs fan, I think it's really important that people.
It's a mental health issue for you. What'd you call them last?
We have Jeremiah Rigsby, Charlie Swanson, and Felicia Higgins. And that's it.
Let's go, team.
Chair Greenlake and members of the committee, I'm Charlie Swanson, a healthcare and democracy advocate from Lane County. I'm also here representing the 27,000 members of Healthcare for All Oregon in support of House Bill 4018. Coordinated care organizations in Oregon serve about as many people as K-12 education does, with about, roughly the same sort of budget as K-12 education. So they have a really important duty to protect taxpayer money that they are using to pay other providers to provide the care. So it seems clear to me that transparency and accountability are incredibly important. The Oregon Health Policy Board has made a number of suggestions that were alluded to earlier to improve transparency and accountability, and I think all of those suggestions need to be followed. The best way to get transparency and accountability is for them to follow public meeting laws. If there needs to be some sort of clause to say, okay, except you can meet in the public with other people and talk to them about how to get better, which is somewhat, they said that was alluded to earlier, put a little amendment in that says, okay, you can do that. You can talk to the public and you can talk with other people in the public, even if there's a lot of your members there, and you can talk about things. Just don't make any decisions behind closed doors, especially financial decisions of using public money to provide health care for the most vulnerable people in Oregon. So in order to protect taxpayer money as best you can, pass at least that part of this bill. We're in favor of some of the other portions of this bill as well. So I would thank you in your efforts to make sure that the vision of CCOs as community organizations is actually carried out. So they actually are community-based organizations or statewide organizations with community-based input. You can't have that without public meeting laws.
Go ahead.
For the record, my name is Felisa Higgins. I'm the political director of SEIU Local 49. I'm here on behalf. Is it getting worse?
Well, that was a little better there.
Okay. I'm here on behalf of SEIU. 75,000 workers. This is super awesome. Here's the gist of this testimony. We support coordinated care reform and transparency. We think it's really critical. SEIU has many members who are members of coordinated care organizations, and we think the reforms that are outlined in the legislation as well as in some of the amendments are critical to the success of CCO reform. I especially think the issues around social determinants of health and health equity are critical components that both the Oregon Health Policy Board should be looking into and digging into, and we have been having numerous conversations about. I think that the issue around the risk-bearing entity was a huge conversation around the first round of CCOs, but I believe if we are community-based organizations, I think that that change can happen. Thank you so much. I think it doesn't hurt. Just to alcohol the right. It's not painful. Just it's sad. I think that if they are truly community-based organizations, we should take that into account. I also think that the amendment, I'm not sure which amendment it actually is, around the dissolution of CCOs and what happens to the money after the dissolution of CCOs needs to be considered seriously and carefully as we move forward with making these changes. And I'm very excited to move forward on the work related to the CCOs 2.0, especially given the next round of metrics and accountability. I think that we have an incredible opportunity. We have a system that's working, and I think that we can make it better and something that we can continue to be even more proud of. And I'm very excited to move forward not only with this legislation, but the next round of contracting with CCOs. So thank you. I'm happy to answer any questions. I'm just going to wipe this down.
Thank you. Are you done?
Mm-hmm.
Thank you.
Forever.
Hello, my name is Jeremiah Rigsby. I work for Care Oregon. Care Oregon owns 2 CCOs, one in the rural northwest portion of the state and one down in Jackson County. And we also provide physical health care and pharmacy care for about 175,000 people in the metro area. I want to testify today in support of the general intent of the base bill. I think we have a lot of faith in transparency and understand the need for transparency as stewards of the public dollar. I think public meeting laws are an easy way to go. It's an easy statute to point to. I think having board meetings open to the public is important. I think there might be a middle ground between throwing everything into public meeting laws and also making sure that the public has access to the ability to know what's happening in board meetings, to show up at board meetings, to provide public testimony in meetings. And finding that right middle ground is kind of the devil in the details, and that's how I think we feel about a lot of this bill. I think we don't have much of a comment on the statewide CCO or about a few other provisions. A lot of the amendments that came out in the last hour we're still working towards. I think every CCO needs to be putting money back in the community. I think it's purely appropriate for the legislature to say you need to focus on equity. I think it's purely appropriate for people to say we talk at a high level about social determinants of health without getting in the trenches and working on it. I think the Oregon Health Policy Board is starting that work as well, and for the legislature to be doubling down on the work that the Oregon Health Policy Board is doing to figure out whether or not CCOs are spending enough money on social determinants of health, and whether that's targeted at the right things is the work that needs to happen. They need to be careful conversations. I will say the -2 amendment around what you do with reserves and making sure that reserves don't disappear if a CCO dissolves is important work. The way that amendment's written is a little troubling, but I think we know the intent you're getting at, and as the CCOs we represent, I think we're really wanting to work with you on moving forward.
Great, thank you very much. I'm going to close the public hearing on House Bill 4018 and open a public hearing on House Bill 4135.
Mr. Chair, Vice Chair, members of the committee, before you is House Bill 4135, brought to you by Speaker Kotek and Senators Prozansky and Senator Hayward. The measure modifies statutory advance directive form in Oregon. I'm going to keep my description short because we actually have the drafter from LC, Lori Ann Sills here. There's no fiscal revenue impact statements are on hold list, no amendments, no subsequent referral.
Then we can move the bill.
Mr. Chair, you have the committee has the paperwork, correct?
You call the first panel. Are you the first panel? Go for it.
All right. Chair Greenlick, members of the committee, my name is Lori Ann Sills. I'm an attorney with the Office of Legislative Counsel. I'm here to discuss House Bill 4135 and the changes that it makes to the Advance Directive statutes. Briefly, I'd like to discuss Oregon's current Advance Directive laws, what this bill does, and what it leaves alone. Oregon has had some form of a health care directive in place since 1977, and the current form of Advance Directive has been in place and unchanged since 1993. An Advance Directive is a health care planning tool that allows a person to authorize someone to make decisions for them when they're incapable of making and communicating those decisions on their own. The Advance Directive has two parts, the instruction form and the appointment form. So the appointment section is the part of the form in which a person can name one or more people to make health care decisions on their behalf when they are unable to do so. It is in this In addition, it's in this section that a person can indicate whether a nominated healthcare representative has the ability to make end-of-life decisions for them. The instructions portion of the Advance Directive allows a person to give specific instructions for healthcare. It lists 4 end-of-life conditions, and the person can indicate whether he or she wants life support and tube feeding for any of those conditions. Alternatively, the person may indicate that she does not want tube feeding or life support for any of those conditions, in any situation, sorry. Finally, the person may add their own healthcare instructions or wishes in their own words. There are 2 main situations when an Advance Directive may be useful. The first is if a person is incapacitated, unable to communicate, and someone needs to consent to medical treatment on their behalf. In this case, a healthcare representative appointed under an Advance Directive may consent to most medical treatment on the person's behalf until the person regains capacity and the ability to communicate. Second, if a person is incapacitated, unable to communicate, and end-of-life decisions must be made, a healthcare representative appointed under the Advance Directive may make those decisions if the appointment form specifically authorizes them to do so. Any decisions the healthcare representative makes must be consistent with the desires of the person that the person has previously indicated to the healthcare representative or in the Advance Directive instructions form. If the principal has appointed a healthcare representative but did not specifically authorize the healthcare representative to make end-of-life decisions, then the healthcare instructions portion of the Advance Directive controls what decisions should be made. Under House Bill 4135, most of this process would remain unchanged. The main changes that House Bill 4135 makes are the following. Throughout the bill, many of the duties and restrictions that apply to attending physicians are extended to attending healthcare providers. Section 9 updates some definitions and removes unused definitions. Section 8 updates execution formalities to allow the option of using a notary. Currently, the only option is for witnesses. Section 7 allows a healthcare representative to accept appointment in writing or by some other form of acknowledgement and specifies when an alternate healthcare representative may act. Sections 5 and 6 incorporate these changes into 2 new statutory forms. Section 5 creates a standalone form for appointing a healthcare representative. This form is substantially similar to the appointment section of the current Advance Directive, with some changes to the explanatory section. In addition, it no longer includes a place for the principal to indicate whether the healthcare representative may make end-of-life decisions. That section has been moved over to the instructions portion of the new Advance Directive form. Section 6 replaces the current Advance Directive form with a temporary Advance Directive form that can be used until January 1st of 2022. The temporary form updates the explanation portion of the form, incorporates the same changes to the standalone version of the appointment form, reorders the healthcare instruction portion of the form, updates some terminology, and places the authorization to make end-of-life decisions in the instructions portion of the form. In addition, it updates the execution and acceptance formalities. Sections 2 through 4 create the Advanced Directive Adoption Committee. The committee is made up of 13 members appointed by the governor who represent the long-term care ombudsman, consumers, healthcare providers, ethicists, and attorneys. Each member may serve a term of 4 years, and the committee is tasked with developing a new advanced directive form within the statutory legal framework and reviewing that form at least once every 4 years for necessary updates. The advanced directive form developed by the committee must include certain elements. Those are listed on page 3 of the printed bill. And in adopting any new advanced directive form, the Oregon Health Authority may require the committee to engage in public notice and stakeholder participation. And in addition, any form adopted by the committee must be ratified by the legislature and the governor before it becomes effective. The rest of the bill consists of mostly technical amendments and relating, operative dates and whatnot. So just briefly, House Bill 4135 doesn't do several things. It doesn't allow the withholding of food or drink for incapacitated individuals. Current law and House Bill 4135 require that comfort care, including reasonable efforts to orally offer food and water, will always be offered. It doesn't allow any unwanted treatments to be provided to a competent person. In addition, even if a person is not competent, if the treatment objected to involves end-of-life decisions, the person can revoke an advance directive at any time. It also does not change the priority order for surrogate decision makers or the threshold for ending life-sustaining procedures. It doesn't affect the physician's orders for life-sustaining treatment, otherwise known as POLSTs, and it doesn't change the effect of an out-of-state advance directive on treatment provided in Oregon. Thank you for your time. I'd be happy to answer any questions you may have.
Chair.
Mr. Chair?
Yeah.
Yes, thank you.
Go ahead.
2 questions, sorry.
Which one of us?
I'm outranked. Go ahead.
Thank you, I appreciate that. You said that under this new committee that would create any form changes, it must be ratified by the legislature. And I guess I want to understand more clearly what ratified means and what that process is. My years of being around here, I don't remember that. Maybe it's...
Chair Greenlick, Representative Kennemer. I wasn't involved in the drafting of that section, and I know from the history of it that it went through several different iterations. And so it's a little bit more complicated, I think, than it needs to be. But the gist of it is that the form has to be approved by the committee. The committee then submits it to a legislative committee on healthcare, and then that committee has to come up with some form of legislation that gets proposed, and it has to be ratified by the legislature and by the governor. There's a question. I have a question about what that means, and I think that that section could use some work to put it into our normal form and style.
Yes, follow up if I can. Go ahead. Some form of legislation. So when it comes to be ratified, it does not come as a traditional bill for statutory form.
It's going to have to come as a traditional bill. It's the only authority we have.
It's the only way it can come.
Well, that's what I was wondering, if this was creating some new process that I didn't understand.
Chair Greenlick, Representative Kennemer, yeah, it's complicated and it's not particularly clear in the language that's there. And I think we can rework that so that it's more the way that we usually say, that the committee will propose the form to the legislature, and then the Legislative Assembly can put that form through the process, and it just gets passed like a normal bill.
And if I could, one more question about this.
It can be improved in the Senate, too.
Well, that's right. I guess, in theory, the same thing could occur. Any legislator could introduce it. You're just creating a committee of presumed experts to put together this document.
Chair Greenlick.
This eventual bill.
You had consensus.
Chair Greenlick, Representative Kennemer, are you talking about the proposed form?
Proposal.
I suppose so. But this is having the committee working on it. You've got a lot of people that are representing a lot of interested parties, and they are educated in this form, what it does. They work in the fields that utilize it, and they're able to work outside of the constraints of the legislative session as far as time constraints to come up with something and then propose that to the legislature for them to consider during the legislative session.
Thank you, Chair Greenlick. Let me ask Oliver first, do we have anyone else speaking in favor of this bill on tonight?
Representative Vile, we do.
Okay.
We're going to have a bunch of testimony until 5 minutes to 5.
But others, the proponents have folks speaking as well as, okay. Then I just have one question, I think, for our legislative counsel. In the roughly 26 pages of the current form, we have a variety of things that are somewhat inconsistent, somewhat unclear. But one of the things that it does do is it allows for us to take out-of-state forms. And when we take an out-of-state form, we subject it to Oregon law. In the bill, on page 13, right at the beginning there, we've stricken that subject to Oregon law provision. Do you know why that happened?
Chair Greenlick, Representative Vile, yes. So that's actually language that used to be used, I think, more frequently than it is today. It's not part of our form and style, and I think that was part of the cleanup of the form, was to take that language out, because it's a given that anything that comes through Oregon is going to be subject to Oregon law. It doesn't have to be said.
So your position would be that as a matter of Oregon law already, any form that came from out of state would necessarily be subject to Oregon law?
Chair Greenlick, Representative Vile, yes.
Okay, just one follow-up, if I might, Chair Greenlick. Having dealt with this for a while, I think you've been around this bill for a few years now. Is the temporary form any clearer, any easier to use than the current form, in your opinion?
She'd love to answer that.
Chair Greenlick, Representative Vile, this is the borders on a policy question. So
I'll withdraw the question.
The advocates point out, and you'll hear, that there are things that make it better than such things as the fact that if somebody's assigned to be your representative, they have to agree to do it. There are issues that they will argue, because I've asked this exact same question.
Thank you.
Okay, we're going to call witnesses. We're going to run out of time.
Whoa, hold on. One more representative has a question. On the other side, to our left.
Yes, go ahead.
Thank you, Representative. I'm the newest member of this committee, so you're going to have to bear with me. Really quick, currently the advance directive that we have, if I am if I'm a patient, what is the default if I don't have an advance directive?
Chair Greenlick, Representative Bowles, if you do not have an advance directive, it depends on what kind of care is needing to be provided. If it is not end-of-life care, Oregon does not provide a way for family members or friends to make those decisions for you. Instead, the hospital will appoint somebody to make those decisions and make the healthcare decisions, or the family can go to the court and get a guardian appointed who will then have the authority to make healthcare decisions. If it's end-of-life decisions, then there's a statutory order of priority about who has authority to make those decisions. And it starts out with a court-appointed guardian, then it's the spouse, the adult children of the person. You'll have to excuse me, I don't have the list in front of me. But and if none of those people can be located, then it's the healthcare provider that can make the decision.
And does the advance directive that we're discussing today, does that change at all?
Chair Greenlick, Representative
Maybe
Bowles.
I'm trying to be too simplistic.
It does not. That stays the same. There's no change to that.
Okay. Thank you.
Okay. We need to get moving, and I'm afraid we're not going to have time for everybody. Please be prepared to submit written testimony for us if we run out of time. We'll give it 2 minutes and we'll go till 5 minutes to 5 where we're going to have a working session on this.
Okay.
Can you please call the first panel?
Mr. Chair, we have Nick Kochler, Sarah Kaufman, and John Bartholomew.
And we'll be alternating for and against.
It's my neighbor.
Chair Greenlick and members of the committee, good afternoon. For the record, my name is Nick Kochler, and I am Regional Director of the Providence Center for Healthcare Ethics. It is an honor and a privilege to be here to speak with you and share on behalf of Providence our support for House Bill 4135. Today, I speak to you from the perspective of a clinical ethicist who practices in Providence Catholic healthcare ministries, including hospitals, clinics, home health, hospice, and ambulatory care centers across Oregon. Ethicists support patients, families, and health professionals through complex, value-laden decisions in circumstances of ambiguity and disagreement. I am drawing on my experience in such clinical ethics consultations, which occur often in conjunction with our palliative care colleagues. We believe that well-documented, values-based advanced care planning in the form of a valid advance directive is an extraordinary gift that a person can share with loved ones. An advance directive helps alleviate the burdens and moral distress of making healthcare decisions on behalf of an incapacitated person facing life-limiting illness. Entrusting someone by explicitly designating them and granting them authority to make your healthcare decisions is an awe-inspiring decision. As healthcare representative or as professional caregiver, having access to a statement of values is tremendous help in ensuring appropriate medical care is delivered in alignment with patient preferences. This vision for best practices in advanced care planning is hindered by the current form that has been in statute for over 25 years. In our consultation service, we encounter many types of issues with the current form. As caregivers, we lament situations wherein a family member must make her best guess about what the patient would want. Does the patient want mechanical ventilation even though it is unlikely he will be able to breathe again on his own? In the absence of an advance directive, which are often not completed because of the confusing form, healthcare professionals may turn to family member by default, and it may not be the person or the patient would trust the most on her behalf. Providence strongly supports House Bill 4135 because it creates a process by which the community can improve the advance directive form in Oregon. Thank you.
Chair Greenlick, Vice Chair Noston Hayden, members of the committee, for the record, my name is Sarah Kaufman, and I work for the Alzheimer's Association. Thank you for the opportunity to be here today in support of House Bill 4135. I want to turn your attention to a letter that was submitted to OLIS in support of House Bill 4135. It's from a broad coalition of consumer advocates, healthcare entities, and legal experts, and I respectfully ask you to please take a look at that document and the supporters of this bill. House Bill 4135 will protect a person's personal wishes when they are unable to speak for themselves. And a properly executed and updated advance directive can be especially helpful in safeguarding the wishes of people affected by Alzheimer's disease and dementia. House Bill 4135 will update the current advance directive form in a manner that will encourage Oregon families to have and document more valuable discussions about their healthcare values and wishes. As you heard, this bill is the result of a multi-year public stakeholder conversation where very different and very diverse viewpoints came together. Excuse me. Came together to make the advance directive form easier to understand and fill out. Oregonians, including individuals with dementia, will not be harmed by this legislation. Instead, it will encourage communications about values and treatment and secure an individual's religious, spiritual, and personal beliefs regarding their end-of-life choices. As Legislative Counsel explained, current law and House Bill 4135 requires that comfort care, including reasonable efforts to orally offer food and water, will always be offered. It's important to keep in mind that the diagnosis of Alzheimer's disease is not an indication of decision-making incapacity. A person with Alzheimer's disease may lack capacity to drive or live in the community, but they retain the capacity to make decisions about the medical care they wish to receive. A person with dementia has a legal right to request medical treatments or to refuse medical treatments. People with late-stage Alzheimer's disease, as they are near end of life and are no longer able to make their own healthcare decisions, loved ones must make decisions on the person's behalf. And when there are clear and complete advance directives in place, Family members can take solace in knowing that they're upholding a person's personal wishes and maintaining their comfort and dignity. Thank you.
Chair Greenlick, Vice Chair Hayden, Vice Chair Nose. For the record, my name is John Bartholomew. I'm the Government Relations Director with AARP Oregon. And we've submitted pretty substantive written testimony, so I'm just going to hit a couple of high points. For us, the most important aspect of end of life is looking at independence, choice, and dignity. And when somebody's independence is lost, it makes it all the more important to preserve choice and dignity. That's where a good documented advance directive comes in. An advance directive form allows a competent adult to choose for themselves who they want to speak on their behalf when they can't, and what they want their health care decisions to be. This legislation makes some changes to improve the form and sets up a more efficient process in the future for future improvements. This is so people can more clearly express their personal values and choices. This will prevent situations where an individual's wishes are left unclear. The current form has some check boxes as opposed to ways to actually write in what you really want. That's one of the changes this bill will make. If you want to be kept alive by any means necessary, or you don't, this will help you ensure that your wishes are fulfilled. If this bill fails, let's be clear what happens. It leaves the existing 30-plus-year-old advance directive form that I find confusing in place. So the choice is between leave the form as is, leading to potential for a person's wishes to be ignored, or we move forward to try to make it clearer so that people can really express what it is that they want when they're put in this situation. Thank you.
Thank you very much. Questions of this panel?
Yeah, you got a bunch of hands just went up.
Vile?
Thank you, Mr. Chairman. Nick, let me start by saying this. You're right. The current 26 to 30-page form, depending on how it gets printed, is a train wreck, in my opinion. I've dealt with it for 35 years as an attorney, and frequently people can't figure out how to fill it out correctly. That said, I don't think the temporary form that's included in House Bill 4135 is a whole lot better, and I'm worried that all we're doing is perpetuating a process where we keep having a committee creating forms over and over and over that are just, frankly, horrible. So I'm having trouble with this bill from that standpoint. But I have a specific question, just policy-wise. If you had the opportunity, would Providence be supporting a situation where no indication is given on the form and a long-term care facility wants to withhold, the person is indicated as the healthcare representative on the form. That person says to Providence, you know what, I do not want my mother being spoon-fed. She's got Alzheimer's, she's going to die anyway. Let's just not, she can't feed herself, but we're not going to have her spoon-fed. Mm-hmm. What would you do in that circumstance?
As I understand the proposed bill in HB 4135, it is specifically scoped out that hand feeding and spoon feeding is not considered artificial nutrition and hydration. So that would not be something that could be left as an instruction in the current form or in any of the proposed forms that would come out of this committee.
And Providence would support that kind of a...
Providence would support keeping it out of the advance directive as a possible instruction.
Okay. So in other words, Providence would not want to be caught in a position where they had somebody that had been given that instruction and they're having to follow that.
Correct. In fact, our clinical leaders tell us that oftentimes hand feeding is among the few social activities that patients have, and to not offer that is tantamount to patient abandonment.
Okay, thank you.
That was me. I was going to clarify that also.
Okay.
Yeah, wait, did you have your hand up,
Yes.
Representative Canterbury?
Thank you. Mr. Bartholomew, I guess I was listening to your testimony, and I regret I have not had the opportunity yet to read through all this material, but you said something that was of concern to me, and as I recall, and I copied down most of it word for word, our choice is now to leave it as it is, or, and this is the part I've got that bothers me, that's a quote, or move forward to try to make it cleaner. And that doesn't sound very well thought through, and I'm concerned about this. My personal history is in 1993. I was one of the central players in the discussion on this bill. And I'm partly at fault for what you had to say, but did our best. But I am concerned that we improve this language and that it be clear and that it be well done. And your statement certainly didn't lead credence to this being better.
Right.
Well, but I think the issue is very clear. It was groundbreaking when you did it in '93. It was extraordinary to be done. And I think it's come to the point where people have recognized that it's a problem and it needs to be fixed even more.
Yeah.
But they're trying to put an intermediate thing in place that improves it until we get to what they believe could be a much better form. I mean, that's basically all it is. Is this the right answer?
So we're going to do a mediocre update. Is that what we're saying?
We're going to do a little improvement is what we're going to do while we get to a bigger improvement. And that might not be perfect either. This is a very complicated business.
Well, it is. Right. That's why I have trouble with a little bit of improvement.
Well, better than not doing any improvement while we wait, I would think.
Well, it depends on what that little bit is.
Well, let's keep moving, because there are a lot of people who would like to have a chance to talk, and we're running out of time.
And that's why we vote.
Could you call the next panel?
We have Bill Harris, Colm.
We are going to have a chance to vote on this tonight, so hang tight.
Willis, Bruce Yella, and Sandra Morehouse.
There you Let's go.
I guess my name was called first, so
Go for it.
I'm Bill Harris. I'm a person who basically spouse died of Alzheimer's in October. I was one who tried to invoke an advance directive, and I was one who was declared as an agent for an advance directive. I'm in favor of 4135 because to me it is a small first step. It is not the final step in the process of advance directives. There are many things that advance directive is omitting that should be in the advance directive, and one of them, which was just mentioned recently, was the assisted feeding on that. One of the things I want to make a point is that there's actually two parts that we have to deal with on an advance directive. The first part is the advance directive itself. And that, I think, we will hear enough comments on the advance directive. The second part is that when I tried to invoke an advance directive of my wife, I got overruled in court because I went to court to try and enforce the advance directive, and the ruling was that it did not supersede state rules. And the state rules were that if she was in a facility, such as a memory care facility, which she was, that facility is required to provide 3 meals a day, and if she cannot feed herself, to assist her in feeding. So even if you have an advance directive and you indicate no assisted feeding, the state rules will override that. And to me, that's why I think 431 is a good process, but it's only the first step in this process. It's going to be nasty, it's going to be ugly, but it needs to be worked through in relation to it. Otherwise, the advance directive has no meaning. Part of the issue is that the advance directive is her statement on how she wants to die. It is not the state statement. It's not someone else's statement. And as an agent for her, I was basically indicating what she wanted in relation to how she wanted to die. It is a right to die document on her terms, and it should be looked at as that way.
Thank you.
Is Colm Willis in the room? Come up. Yeah, so please come up, please. We'll sit you on a chair here. Yeah, we'll get a chair. Thank you. Yeah, thank you. Sorry.
Ready?
Go ahead.
My name is Bruce Yelly, and I represent a brand new Oregon nonprofit named End Choices. We are currently working with Senator Roblon to expand the Oregon Death with Dignity law in 2019. He will submit a bill to expand that to include more people that are suffering, such as the people we're talking about here, where the doctor will not give them a 6-month end of life designation. Excuse me, I have Parkinson's and a couple of diseases, so I apologize for my presentation. I was encouraged by our representative to come in here.
Fine.
I didn't plan on doing it.
Fine, let's go.
So anyway, this council fits right in with what we're talking about doing. We would have been here last year to promote it, but we were very sick. If this does not get put through this year, we will be back next year because we believe a council is needed to govern the death with dignity laws. We're tired of seeing people that are laying in bed for 10, 12 years that really don't want to be there, and the doctor won't tell them they only have 6 months to live. As far as dementia, we believe that you should be able to draw a line when you are diagnosed with an incurable disease that's causing suffering. Draw a line and say, if I have dementia, when I reach that point, to me is when you put me in memory care, when you have to give me a dependent. I don't want to be dependent on anybody. There is my line in the sand. If I'm coherent when I reach it, I can decide again. If I'm not coherent when I reach it, the council is obligated to medically end my life for me. And this is something that will be up next year with Senator Roblin sponsoring it, and I do have permission to use his name.
I'll be there to help that one if I can.
Pardon me?
I'll be there to help that one if I can.
I have hard of hearing.
You'll be here to help.
You say that's a different topic, but I'll be there to help you when doing that one.
I was planning on talking to you. I think I emailed you. Anyway, I used my funds to do this completely. I am going to start taking donations. My tax exempt is into the government.
We need to go on. Thank you. Please go ahead.
Chairman Greenlick and committee members, thank you for letting me speak to you today. I'm opposed to the House Bill 4135 because of the things.
Name, please?
Oh, I'm sorry. My name is Sandra Morehouse, and I live in Washington County. I'm opposed to this bill because I think it has a lot of problems, as people have been saying. I'm here to represent the most vulnerable people in Oregon, the mentally ill, and those with dementia, and I want to make sure that they get protected. Well, here we are again, less than a year later, still fighting this culture of death. How do we get to this place, and how can we avoid it? I know a lot about people with mental illness because for the past 28 years I have worked as an activity director, a life coach, and a giver of care for people with some form of dementia. And I also know about people who are in the active stage of dying. When a person is in the active stage of dying, they're usually in bed with their eyes closed and their mouth open because breathing has become more difficult. They're not looking for a meal, and they're not really in need of anything. I think that those that have written this bill perhaps don't have a clear picture of what that death looks like. I have had in my care many people, hundreds of people, and none of them have ever said to me, I want to die. I found that even those with advanced dementia still have the will to live, and they have joy in their life, and they aren't in a hurry to end that. It could be a favorite meal, or a visit in the woods, or a love song to sing, or a baby to hold, or a puppy to pet, just simple pleasures. I can't imagine what it would be like if caregivers were all of a sudden told that they actually had to withhold food and water from some of their residents, starve them to death. You would need to be very desperate to die to be willing to be starved. Despite the temptation from some doctors and insurance companies to find a cheap answer to this expensive problem, we are all equal. people with disabilities, or terminally ill people, as those with dementia and other mental illnesses, are no less human than any of us in this room. In fact, if statistics prove correct, half of the people in this room will one day have dementia.
I'm going to need to ask you to wrap it up.
Pardon me?
I'm going to need to ask you to wrap up, please.
Oh, thank you. Thank you for hearing me today.
Okay. Thank you. Go ahead, please.
Chair Greenlick, Vice Chair Noss, Vice Chair Hayden, and members of this committee. My name is Cullum Willis. I'm an attorney with Lynch Conger McLean, and I'm here at the request of Oregon Right to Life to ask you to oppose this bill. This bill would remove important safeguards in our advance directive statute, which would put vulnerable people in our community at risk. Our current law provides that a healthcare representative may withhold or withdraw life-sustaining procedures and artificially administer nutrition and hydration only if the incapable person is in an end-of-life situation or has affirmatively given their healthcare representative the power to do so in writing in an advance directive. If the incapable person is not in an end-of-life situation or is not given this authority in writing, then the healthcare representative does not have the authority to end an incapable person's life. And this is how it should be. But this bill would eliminate this protection, meaning that simply by appointing a healthcare representative, you'd be giving the person the authority to end your life, even if it's not what you wanted, and even if you're not in an end-of-life situation. Additionally, this bill removes the current explicit requirement that an out-of-state advance directive be given effect subject to Oregon law. This is problematic because just last year, Mr. Harris, who's here, came to Oregon from California and argued in Jackson County Court that spoon feeding was a health care decision that he had authority to withhold from his wife under California law. But under Oregon law, spoon feeding is not a health care decision. Thus, it's important that we continue to explicitly state that out-of-state advance directives will only be given effect subject to Oregon law to ensure that healthcare representatives are not able to deny ordinary food and water to incapable patients. For these reasons, I respectfully ask that you oppose House Bill 4135. Thank you.
Thank you very much. Any questions? Well, I'm afraid I'm going to have to close this public hearing on House Bill 4135. I'm really sorry we didn't get to hear everybody. We really appreciate that. You'll have a chance at it at the Senate, because I expect it's going to go there next. An open work session, House Bill 4135. Have the motion.
Chair Greenlick, I would like to move House Bill 4135 to the floor with a due pass recommendation.
Representative Knowles moves House Bill 4135 to the floor with a due pass recommendation. Discussion? Representative Hayden?
Thank you, Chair Greenlick, and thank you for everybody that came to testify on this. I know one came from over 100 miles.
You got to testify.
So we got to testify, so we got that in. That's why there was a mixed panel, which is a little unusual, but we wanted to make sure we got that in. I just want to state for the record that we're very concerned with having Oregon be responsible for adopting multiple different state rules. If you have an advance directive from another state under this proposal, that we would be responsible for whatever state people came from rather than the laws in Oregon. I'm also very concerned.
Has the council testified that would be subject to Oregon law?
They did.
That you didn't have to have it written in there because it automatically under Oregon law it would be. I think that is what she testified.
Well,
involved. Did you?
Just one last comment.
I'm sorry. Go ahead. I didn't mean to interrupt.
My other concern with this is my reading of it. It actually expands the authority for somebody else to make a decision, even though you're not in the final stages or terminally ill. You know, say within 6 months or something. So it expands that to where it could be decided for you, even if you don't have a terminally ill condition. So I'm concerned about those. So I'll be opposing the bill.
Representative Cameron?
I guess I would like to say that I personally object to having a vote on this bill at this point without more testimony and more opportunity to study it. Some of it is perhaps my fault. I recently had surgery, not functioning at 100%, but I haven't had an opportunity to read the latest draft. And frankly, from the testimony, I'm quite concerned. As I said, when I was in the Senate in '93, we spent, I don't know, I guess personally I had well over 100 hours into working on the best document we could make, which I'm not going to argue about its quality. I think we just did the best we could. And I think it's high time to update it. I can't argue with that. But I do think we haven't had the discussion, we haven't had the input, and some of us haven't had the opportunity to look at this thoroughly and make a fair and accurate evaluation. And that's my position, and I'm not prepared to vote on this today, and I would ask as a courtesy that it be laid over.
Representative Weil?
Thank you, Chair Greenlick. I frankly also have some pretty severe concerns about not feeling like I've been able to wrap my head around the very significant complexities of this bill yet. I will tell you that I am conflicted because a lot of my friends in the legal industry and the healthcare industry have worked very hard to get to this point, and I know they have done their very best to try and make effort to get a better form. But frankly, I'm of the opinion that we ought to have 5 or 6 core principles that Oregon feels like are important. Let folks draft their own, whether it's the lawyer, the hospital, or whoever is working with the family, draft their own form. And I am not convinced that the temporary form or any form that's going to be created by a commission, as is proposed in this bill, is likely to do any better than the form we have now. So it's with some reluctance and with some reservation, but I cannot find it in myself to support this bill at this time either.
We're all going to talk, so you might as well.
I think Representative Bueller raised his hand, and maybe Representative Boyles did too.
Representative Bueller?
Yeah, I share Representative Weil and Kinnemer's points. This is much too rushed for such a complex and significant piece of legislation. This is the first hearing we've had on it. There's been discussions for over a year on this. There's been lots of disagreement, and I don't think it's any significant improvement over what we've seen in the past. And I think we're missing an opportunity here to go down more the route that Representative Weil outlined. Personally, that's what I've done. I've outlined more specifically than any form what my end-of-life wishes would be, and I think all Oregonians should have that kind of opportunity.
So as I mentioned, you know, I'm new here, and this is a really big deal. I'm neither an attorney or a healthcare provider, but I have been the appointed designee both for my grandmother and my mother, and I was with them when they both died. So this is really personal, and it's not just personal to me, it's personal to everyone who faces this. So I appreciate both parties on sides of this issue reaching out to me and educating me as much as I could get in the last 2 days. But I would also agree, I am a no on this, but I agree that I would like to pause because this is, it should be fought hard. I mean, we're talking, you know, it's a life and death situation. And so I just want to make sure that we go forward with something that is truly representative of protecting people. And I've been in the hospital, and I remember watching it, and at some point, and whenever I have a moment of time, I'm going to be an advocate because there are a lot of people who don't have people who are walking with them through difficulty. And so it's our job as legislators to protect those people, and I'm not convinced that we're quite there yet.
Thank you. I'm going to make a couple of comments. One, directly, Representative Kinnemer, you know in past days you've asked for things to be held off, and I've been very responsive.
Yep.
We're in this short session, there's just not time. This is not This is not a new version of the bill. This is the only version of the bill. And I think we're just going to have to vote on it. I'm sorry that it's getting split the way it's getting. To Representative Weil, I couldn't agree more with what you say about, I think putting a form in statute is not the best way to do it. I think we should have the 5 principles of what a form ought to take, and we ought to be able to create that own form. But I've learned to live with the fact that what's perfectly obvious to me is not necessarily obvious to anybody else. It's just sort of the way it is. This group that's worked on this form has worked long and hard, and it really is a well-balanced group. And I'm hoping as they move forward, maybe they'll think of another option, but I think the notion of a form and statute is very odd. But I really, in criticism of the existing form, I really think we need to remember it was an extraordinary job. We were very early in this, and you guys in the Senate at that time worked very hard. There will be a chance. I am going to vote. I am going to call a vote on it. I hope it passes. I hope it moves to the Senate. I hope it doesn't become a partisan issue rather than an issue where people disagree on substantive issues. But I think we need to take a vote on the motion. Yeah. Can we stand at ease for a moment, please?
Way too much.
Who?
Sorry, yours.
Did you move this bill?
I did, Mr. Chairman. We have had a lot of discussion about it.
We're in work
Sorry,
session
please.
now.
We're in work session, please.
Will you withdraw the motion?
Okay. All right. Thank you, Eddie. Great. Thank you.
You want me
Will you withdraw the motion?
You want me to withdraw the motion?
Withdraw the motion. We're going to
Chair-
carry over.
Chair Greenlick, I would like to withdraw the motion to send the bill to the floor with a due pass recommendation.
Representative Lewis has withdrawn his motion. I'm going to close the work session on 4135 and carry it over to Friday.
No.
We'll go in recess now. We'll reconvene at
6 o'clock.
6 p.m. Get a bite to eat and take a deep breath. We're in recess.
Okay, members of the committee, we have a lot of people here that want to testify this evening, and this will be one of the few opportunities I'm going to get in the short session to open our committee as the acting chair for a brief moment. While the chair of our committee and 2 of our esteemed colleagues from the other side of the building kick off our hearing on, I know I should know the
HJR 203.
House Resolution 203. Thank you, committee staff. And with that, we'll ask the members of the esteemed panel to kick us off, and please introduce yourself for the record and keep your remarks brief, Mr. Chair. 2 minutes.
Hey, Rob, start the 2 minutes. Just cut me off when you get tired of hearing from me. I'm State Representative Mitch Greenlick.
Microphones are on.
Microphones are on.
Get a little closer to you, Mitch.
They're not.
We don't.
They are up as loud as they can go.
We'll just have to be a little closer. So,
Yes.
yeah.
Yeah, well, and basically the mics are for recording rather than for amplifying, unfortunately. I am delighted. Thank you for inviting me to testify on House Joint Resolution 203, Mr. Chair. I'm really delighted to be here. The story on House Joint Resolution 203 goes back to 1988, where Governor Goldschmidt invited me to join a panel on health care for the uninsured in Oregon, believing there was a problem with having access to health care. There clearly was a problem at that time. The uninsured rate was probably around 20% of the state, and the panel went to work and spent 6 weeks essentially inventing the Oregon Health Plan. Within its original form, had 3 elements to it: a high-risk pool, modification of the Medicaid program, and a small business mandated to provide health insurance for employees of small businesses in Oregon. It was passed over to an obscure Senate president at that time, a fellow named Kitzhaber, who put together the notion of the prioritized list and guided the Oregon Health Plan modification bill through the Oregon legislature. It became the health plan as we know it now, and it began to tackle the question of the uninsured rate in Oregon. Fast forward to the year 2003 when I joined the legislature. In that year, the uninsured rate was 15%. The Oregon Health Plan had been modified a bit during that session with the Healthcare Committee of the House leading the way. We created the provider tax as a way of centralizing the health plan. And we began moving seriously toward the notion of universal access to health care. In fact, the bill that defined the Oregon Health Plan in the first place created the statement that health care was a right of all Oregonians as a statutory matter. With the partnership of the federal government, we moved forward and reached the point we were last year where 95% of Oregonians were covered for had access to health insurance. And it seemed simple at that point before the presidential election of last year to believe we would move to universal access in partnership with the federal government. It became clear in the last year that the federal government is an unreliable partner in moving us towards universal access to health care. But that doesn't stop the notion that Oregonians have expressed periodically in a variety of ways that health care is a right and everybody in Oregon ought to have access to affordable and effective health care. Now, given that, given the fact that actions in Washington, which are going to get worse by many of us believe, because the House leadership in Washington, D.C. has taken on the notion of dealing with entitlements, which seems to me to be Social Security, Medicare, and Medicaid. And given the fact that they seem to be having a war on progress we've made over the last 25 years, Oregon needs to be ready to move forward on its own rate toward universal access to health care for Oregon residents. In aid of that, we've done a couple of things. We've started a work group of this committee under the chair of Representative Salinas to begin to ask what is it we need to know in order to have a serious look at universal access to health care in the year 2019. But what also, it seems to me, would be useful for helping us figure out what we want to do in 2019 when we begin to take this seriously is to ask the voters of the state if they do believe, as I believe they will, support the notion that every Oregonian has a right to health care as a fundamental right. What House Joint Resolution 2003 does is it sends that proposition to the voter, to ask the voters in the general election of 2018, do they or do they not believe that the Oregon Constitution ought to implement the right of all Oregonians to have access to affordable, cost-effective, and quality medical care. That's what the bill does. That's what I'm asking the committee to be voting on later today. And with that, I'll be happy to answer any questions.
Do you want to, why don't we hear from the other members of the panel, and then we'll go ahead and take a few questions.
And I'm happy to let my more senior colleagues go first. I'll back clean up.
Thank you, Vice Chair Nose and members of the committee. I am so delighted to be a chief sponsor on HJR 203. When Representative Greenlick came to me, I said, Mitch, I have believed that health care is a right since a few years after I became a public health nurse. And Oregon, you know, has been a pioneer in the health care delivery system, and to just make it more effective, affordable, and accessible. And what HJR 203, it enables Oregon to be a model for the rest of the nation. Already we have 95% of Oregonians that are covered with health care, but there are still far too many that are not able to access health insurance or access care because of high costs. As you all know, with the recent election and the public opinion polls, there's a strong majority of Americans that believe it is the government's responsibility to ensure that all residents have health care coverage. HOPE, as we call it, HOPE cements that value by enshrining the right to health care in the state constitution. I didn't always believe this, but as a public health nurse, I have worked with at-risk and low-income families who did not have access to health care due to a number of reasons, but poverty was the primary reason. But let's remember, Oregonians should not have to choose between paying rent or getting care they need when they are sick. Preventative care like checkups and tests for chronic illnesses will ultimately improve the overall health of all Oregonians. Healthy Oregonians makes a healthy economy, a strong educational system, and a safer community. And I'm very happy to support HOPE.
Thank you, Vice Chair Nose, members of the committee. For the record, I'm Lee Byer, State Senator from District 6, which includes the central portions of Lane and Lynn counties. Representative Greenlick has given you the background on his play-up. I'm going to be real simple and say I have felt for all the while I've been in the legislature that Oregonians deserve the right of health care. A country as rich as ours ought to be able to provide basic health care, just like every other industrialized nation in the world. It's not only a goal, it is a right, something we work to. How we get there, I'm not sure. I'm very pleased to see the House Task Force working at some of that. Help Representative Salinas any way I can to get there. But it is something we need to put out. I think it's, you know, we have strong feelings. I have strong feelings. We'll see where Oregonians are. I trust that they're going to send a solid message, which not only will affect us and future legislatures, but also will send a clear signal to our congressional representatives of where Oregonians, the people they represent, are. So I strongly encourage you to move quickly on this. Let's put it on the ballot and let Oregonians have a vote.
Thank you, Vice Chair Nose, members of the committee. For the record, Elizabeth Steiner Hayward, Senate District 17, Northwest Portland and Beaverton. You know, I get teased a lot about talking about the fact that I'm a physician, right? I do. And I've decided I'm going to own that and live with it, and I'm proud of it. Because I decided I wanted to be a physician when I was 4. Over 50 years ago. All right? And I've stayed a physician, and I still practice as a physician because I believe, as my co-panelists do, as I believe the vast majority of Oregonians do, as they proved with their vote on Measure 101, that for people to be healthy is a core value of our society. And it is no different from the right to an education that is already enshrined in Oregon's Constitution, in Article 8 of Oregon's Constitution. It is fundamental. It is impossible to be well educated if you are a child with untreated asthma. It is impossible to be well educated if you are a young adult with diabetes, with this uncontrolled, and you're trying to decide if you're going to pay for medication or textbooks. It is impossible to be a productive employee
If you're missing work due to chronic health conditions, or you're less productive, you have what we call presenteeism. You're there, but you're really not doing what you could be doing. In November of 1990, I had the privilege of coming to OHSU as a fourth-year medical student to do a sub-internship in family medicine. And it was while I was here that I first learned about the Oregon Health Plan. It was, for all intents and purposes, one of the 3 key reasons I came to Oregon to do my residency training and have never left. Oregon made the decision a long time ago that instead of providing more services to fewer people, we were going to provide fewer, cost-effective services to more people. That's what our prioritized list does. That's what we must continue to do. You will, to achieve that end, see in front of you a -1 amendment that just simply adds the word cost in front of the word effective in there, because it is important that this not be a wide open blank checkbook for unproven, non-evidence-based treatments. We must focus, when we're providing core health care, just as every other industrialized nation does, on evidence-based treatments that are going to improve the health of more people for fewer dollars. Ultimately, for this state to have a sustainable economy, we have to have a healthy, well-educated population. This resolution, when the voters of Oregon approve it, which I believe they will in November of this year, with your support, will agree that for the long-term well-being of our state, we have to come together and do this. Now, it's not going to be easy. I'm not going to claim we're going to wave a magic wand. But frankly, there is more than enough money in the combined health system between Medicare, Medicaid, and all the commercial insurance for us to come together and figure out an affordable plan that ultimately will cost everybody less, because people will be getting the preventive health care they deserve. It won't be tied to employment necessarily. It won't be something that you lapse on and off of and have to switch providers. This is ultimately about doing what I came to the legislature to do, which is to make Oregon the healthiest state in the nation. That means being the best educated state. That means having a sustainable economy. That means having a robust transportation and transit infrastructure. But first and foremost, it means enshrining the right to health care in the Oregon Constitution. Thank you in advance for your support.
Mr. Chair, if I may add one thing.
You may.
Governor Brown has authorized me to announce that she supports HJR 203.
Okay, we have a question from Representative Vial.
Well, a statement first. I find myself surprised to be sitting here on Health Committee when I had a 35-year career in real estate law, but I've learned more in the last couple of months than I could have possibly imagined, and I'm flattered by the appointment to sit with Representative Salinas and discuss this very important matter. And I have learned, as Senator Beyer pointed out, that we really are behind the 8 ball here in our country in terms of providing health care. That said, I'm really nervous because of 2 things. And I get teased a lot about being a lawyer, doctor, so I'm gonna own that too. And my lawyer hat says, how can we go to the voters and really explain the complexities of what it would mean to have a universal health care constitutional amendment in light of our reliance upon federal dollars as they are. In other words, if we are going to have a plan that really does this, don't we have to wean ourselves from the rest of the country? And when we do that, can we really ask the voters of Oregon, who have indicated so much of a lack of trust in entrusting with us their tax money already, to push ourselves further away from that federal dollar plan where we're trying to do this all on our own? The complexity of that just actually boggles my mind, but I would be very interested to hear your views on that.
Briefly.
Briefly indeed. Well, I'll ask my colleagues to share the view, but it seems to me it's not a complicated matter. It's a very simple matter. The simple matter is every human being deserves the ability to have access to effective and affordable medical care. It's that simple. Are we going to make it happen? We're not necessarily going to wean ourselves from federal dollars. We'll certainly take advantage of as many federal dollars as we can find in the Medicare and Medicaid and other sorts of budgets. And this isn't determining a specific way we're going to do it. But I'm willing to bet on the ingenuity of Oregonians to find a way forward. We've led the country for the last 20 years in moving forward, and I think we can lead the country into a more golden age in healthcare.
If I may, thank you. Mr. Chair, Representative Weil, I appreciate your concerns. I would point out that Article 8, Section 3 of the Oregon Constitution says, and I quote, "The Legislative Assembly shall provide by law for the establishment of a uniform and general system of common schools." Period. That's all it says. Everything else about our public education has been statutorily defined. Assuming the voters agree with us and pass this in November, we're not going to transform overnight. This is going to be, as the Oregon Health Plan was, a multi-stage process, because you're right, it is complex. And you're right, it's going to take negotiation with our colleagues in the business community and with our colleagues in Washington, D.C., and we're going to have to figure out how to leverage every dollar we can get. But I think we can easily make the case, ultimately, that first of all, we do have the ingenuity. We figured out the Oregon Health Plan. We're the only state in the nation that did that. We're still the only state, and our healthcare costs are lower for our Medicaid population. We're doing things that no other state's doing. So I firmly believe that we have the brain power in this state to figure this out over a period of years, just as we have with the Oregon Health Plan. That didn't happen overnight. This won't happen overnight. But we need to enshrine the right in the Constitution to give us the authority to move forward, to empower the people with the ingenuity, with the knowledge, with the passion for this, to find this path forward. There is no fast solution. And part of it has to do with the task force that Senator Beyer and Representative Noss are chairing as well on healthcare cost containment, right? We need to be looking at cost containment. That's part of this puzzle too. We're doing some of that groundwork now with that task force, both on the hospital side and other aspects. Part of it has to do with controlling pharmaceutical costs. Again, my thanks to Representative Noss for his hard work on this. So it's a big, gnarly, multifactorial problem. I agree. And we got to start in the right place. And that means putting in our Constitution just like we did for a K-12 education.
So your proposal would be to make it just as simple as the education statement?
That's what the bill says. The bill says...
And just as simple to solve.
Right. Look, I don't think any of us is naive, right? We don't think that we're going to pass this and we're going to solve the problem of funding and structure and how we do it all overnight. But neither did the people who founded this great state in 1859 when they wrote this into our Constitution. It's going to take some time.
Representative Hayden. Thank you, Chair Noss. I like the sound of
that. Don't get a big head there, dude.
Well, I want to commend the panel for your dedicated and lifelong careers, this in part working towards better health care in Oregon. I think it's a commendable thing. And for the record, Mitch Greenlick and I looked at this bill. He talked to me a lot about this bill. I do notice that I asked for a one-word change on that, and he told me that wasn't possible, but there apparently is a one-word change possible with that.
It was a change to improve the bill, not to make it worse.
Touche. And so my concern with this, even though I am a supporter of health care, the one word that I wanted to change was from right to need. Our population has a need for affordable, high-quality, cost-effective health care. When you put it in the terms of a right, it seems to me then we are putting education and healthcare in a bucket that then will compete more directly for dollars. Our graduation rates are not good enough got 95% of Oregonians covered on health care. So my concern is going down the road that we create a lawsuit type environment over this health care and force funding out of other very, very important programs. So my question is this a step to single payer, and what are the funding mechanisms to make sure that we're able to achieve this, or just some concepts on it? Chair Greenlee.
Well, I don't see it as a step to any particular solution. What it does do is open up our opportunity to discuss a lot of the solutions and to see which ones actually serve the best model. That's exactly what I hope the task force will do, to give us the information that allow us to say what are our options and how do they work. But this does not presuppose any particular solution. What it does presuppose is that we have to look at it as a whole population. We're dealing with 4 million people, and if we find ways to integrate the care for those 4 million people, I believe, as my doctor colleague believes, that we can find a way to make it more efficient.
Thank you.
Okay, I don't see any other questions from the committee. You're gonna keep letting me drive the car, or are you gonna come down?
I'll let you drive as long as you want. You help your learner's permit.
All right, can we have Martin Taylor, Savannah Jensen, and Austin Putnam?
You good? Excuse me, let me get out of the way.
It's fun.
Chair Greenlick, members of the committee, for the record, my name is Martin Taylor. I'm the executive director of the Oregon Nurses Association and started that job in August, so about six weeks old on that job. It is a return, though. I did represent ONA for 11 years at one point, so I'm back. I wanted just to introduce the panel first so that if you ask tough questions or whatever else, you could direct them at me. But we have an ONA member, Savannah, who's going to testify first. Then I'm going to give testimony, and then we have a consumer representative, Austin. So with that, I'll turn it over to Savannah.
Chair Greenlick and members of the committee, thank you for the opportunity to offer testimony and support for House Joint Resolution 203, the HOPE Initiative. My name is Savannah Jensen, and I'm a registered nurse at Providence Newburgh Medical Center, and I'm here representing the Oregon Nurses Association. As a bedside nurse, I see an immense difference in outcomes when a patient has been able to have primary care checkups, receive education on chronic diseases, or get routine tests for potentially life-threatening illnesses. Too often, positive health outcomes are reliant on whether a patient has had the ability or privilege to be able to afford and access health insurance. Thanks to the Affordable Health Care Act, 95% of Oregonians have access to care. However, it is critical that as a state, we're always working to ensure that 100% of Oregonians are able to get the health care that they need and deserve. By enshrining the right to health care in the state constitution, we will take a critical step in continuing to foster a lasting and transformative healthcare system for decades to come, even in the face of national uncertainty. As nurses, we are bound by a code of ethics that puts the patient first, whether the patient is an individual, a family, a community, or a population. It's time that Oregon codified the commitment to patients and our community by ensuring access to quality, affordable health care in our state constitution. The HOPE Amendment is an important step for some of the brightest minds in healthcare to come together and find solutions to make sure that all Oregonians can meaningfully access and afford comprehensive health care. On behalf of the Oregon Nurses Association, I ask for your support for House Joint Resolution 203. Thank you.
Chair Greenlick, members of the committee. So, Oregon Nurses Association represents about 15,000 nurses, but in many respects, it's the voice of nursing in Oregon. And so as I returned, one of the first questions I asked is, where are people were our nurses, were our members, on the issue of universal access to health care. It wasn't lost on me that in 2008 I testified on this, on the Hope Amendment in front of the House committee with Chair Greenlick, and it's 2018, so I don't know what that says about Mitch and I, but at least persistence, some tenacity is involved. But I need to know, I was gone for 9 years from ONA. Where are the members? The number one policy issue that surfaced on a survey of over 1,000 of our members was healthcare for all. As it turns out, an ONA member is the chair for Oregonians for healthcare. Healthcare for all Oregonians. And when I posed the question at our strategic planning retreat, where our leaders from across the state participated, it was one of 2 top issues that they wanted to address in the next 3 to 5 years. The appetite, the intensity among nurses to address this issue has grown in the last 10 years, not diminished. And I kind of wanted to know why. So the HOPE initiative is our number one priority in this 2018 legislative session, and if it makes the ballot, it will be a priority for us in that ballot cycle. But where does that intensity come from? And so I've asked a lot of our members, and I found 3 answers that seem to come up the most often. And the first is the same answer that you heard, which is healthcare is a right. It's just simply how nurses associate with their code of ethics, and it is a belief that comes from the assumption that people can enjoy their other rights to life and liberty and happiness if they don't have health. So it's an enabling right to the other rights that we all take for granted. There's a second answer, which I thought was a really unique nurse perspective, which was when we provide care at the bedside, it isn't to someone who's insured or not insured, to someone who is any more privileged or has any more right than anyone else. Every person that you care for is the same in the eyes of the nurse. They're there to make sure that person is cared for in that moment. So of course they don't distinguish between some people having that right and some people not having that right. It's a given. It's a fundamental. That's why they're there. And then there was a third, and that third really is the journey of the last 10 years, and it explained how the intensity had lasted. So when I was at ONA last, when I testified here in 2008, 1 in 5 Oregonians did not have access to health care. And the stories that we told as we tried to do healthcare reform and work with the legislature to expand coverage were the stories of people who lost limbs because their diabetes wasn't treated. They were the stories of people who had kids that missed school with toothaches. They were the stories of people who had to choose between taking care of a loved one or losing their house. So it was health or house. The stories of bankruptcy. 1 in 5 Oregonians was a lot of people to have in that situation. And the ONA and all of us have worked very, very hard in the last 10 years at healthcare reform. As a matter of fact, Oregon is a state that is the tip of the spear in healthcare reform. We're one of the most progressive states in the country at a period in American history where healthcare has broader coverage in this country than any time in American history. So we are, in fact, right now in Oregon, covering more Oregonians than we have ever covered in healthcare, and are a state that it's a cutting edge. We've done this. And now there's fear. There's fear that we finally got to this place where something like the HOPE initiative is possible, and it might all slip away. And so, of course, there's intensity. And just think about the legacy that ONA has shared with you as lawmakers, as policymakers, and as Oregon citizens as they affirm this on the ballot with Measure 101. Think about how that legacy is in peril. And this is a right to say we won't go back. We will not go back to the time where 1 in 5 Oregonians was at risk. The reality is with 95% of people in an insurance product, 95% of this HOPE amendment presumably is covered right now. And some of that 5% that aren't are people who choose not to have coverage, and the HOPE amendment doesn't require it. So when we were talking about this in 2008, we were talking about having to come up with a way from policy to cover hundreds of thousands of people. We're not talking about that now. We're largely, from a policy perspective there, we're talking about not losing the ground we've gained over 10 years of your hard work. This is a backstop. And to protect this backstop, ONA will be here in the building to try to get this to the ballot, and ONA will be fighting when it goes to the ballot to make sure that it passes. And we expect success like we had with Measure 101. We do it because we believe in the right, and we do it because we don't want to go back. I want to mention one other thing. Dramatic pause. I came here in 2008 and found myself in the middle of a debate about positive and negative rights and other things that, to be honest, I had opinions on, but they weren't informed opinions. We do have ONA's attorney with us today, so if anyone wants to have a debate, Tom Doyle's been in front of the Supreme Court debating rights multiple times in his career. If you want that debate, you can have it with him. I'll bring my informed expert up.
We'll have a different day.
Chair Greenlick and members of the committee, thank you for the opportunity to testify in support of House Joint Resolution 203 to enshrine health care as a human right in the Oregon State Constitution. My name is Austin Putnam, and I'm able to access health care through publicly funded health insurance. On January 9th, 2009, my friend Lauren and I were walking down a sidewalk when two drunk drivers crashed into one another. The collision sent a speeding Volvo directly into my friend and I. My right leg was amputated instantly, and a fifth of my left thigh was degloved. I also suffered cranial damage. After my stay at the hospital, I was in bad shape financially. I applied for disability and was denied for 2 years. It wasn't until I obtained a lawyer that my case was approved. I depend on Medicare. My prosthetic leg costs thousands of dollars and needs replacing every 3 years. Without Medicare, my situation would be dire. Although my healthcare access may be relatively safe, too many people don't have that reassurance. In the face of significant turmoil when it comes to health care at the federal level, far too many people on the cusp of OHP eligibility are left wondering if they will still have health care this time next year. Too many people who buy private insurance through the marketplace are worried that their access will evaporate. And for too many, myself included, access to insurance does not necessarily equate to affordable health care that Oregonians can actually utilize. But as a state, we now have the opportunity to take the first step in ensuring that 100% of Oregonians can meaningfully access care across the state. Oregons have spoken loud and clear. We believe that health care is a fundamental right. It's time that our state Constitution reflects that shared value. The HOPE Initiative makes Oregon's commitment to equitable health care crystal clear and offers an important platform for some of the best minds in health care, including providers, insurers, hospitals, patients, and consumer advocates, to come together to make sure Oregon is living up to our full potential, to give every Oregonian the opportunity to live a healthy and productive life. Oregon has been a pioneer in expanding innovative and effective care, and this is the next step. For Oregonians like me, hope is reassurance that our ability to get the services and medication we need can simply be cut off tomorrow, next week, or next year. It sends a message that our state truly cares about every single Oregonian. It's time to put a stop to the uncertainty about health care in Oregon. I urge your support of the HOPE Initiative. Thank you.
Thank you. You call the next panel, please. Our last panel is Tony German, Mark Thompson, and Charlie Swanson.
Start. Representative Greenlick and members of the committee, thank you for allowing me to share my testimony in support of House Joint Resolution 203 today. My name is Tony German. I'm a resident of Silverton, Oregon, where I practice as a rural family medicine doctor. In addition to my role of delivering day-to-day care, I am clinic director of a primary care community health center in Woodburn, Oregon, where we help over 15,000 community members. I would like to start my comments first by asking a question to this committee. What is the worst news you've ever had to deliver to somebody? I hope to offer good news to my patients most of the time, but frequently in a doctor's office, bad news is part of the job. Telling someone they have diabetes, heart disease, liver failure, or worse yet, cancer is no easy task. It is even more disturbing when the therapies to treat their condition are available, but their lack of affordable health care prohibits our interventions to heal them. Although 95% of Oregonians now have health insurance, still far too many of my patients lack affordable access to the services they need. This lack of basic health care has consequences. It sanctions suffering, promotes poor performance in school, and discourages the ability to be part of a healthy workforce. During my time in practice, I have seen our increase in access to care through the ACA and OHP expansion. I promise you it has changed lives and health outcomes. For example, one of my patients received OHP in 2013. Prior to that, he was in the hospital or emergency department on a regular basis for chronic obstructive pulmonary disease. For the last 4 years, due to controller inhalers and smoking cessation, he has not had any complications of his disease, and his quality of life is infinitely better. Many of my diabetic patients skipped meds prior to having health care. They are now much more consistent with their disease management with it. Insulin is a great deal cheaper and respectful way to treat a human being rather than offering them dialysis. The HOPE initiative simply states that Oregon has the capability and willpower to ensure everyone has a chance to beat the death sentence of cancer, to screen for children's developmental milestones so they are ready to learn in school, and to prioritize a workforce that is not put on disability because their injury was not attended appropriately. In my view, everybody has a pre-existing condition. It's called chance. We will all get sick or injured. The HOPE initiative lifts our communities up and enshrines in our state constitution that health care is fundamental to our core value system. In the face of national uncertainty, Oregon must continue to enhance access to care, not go backwards when thousands lack insurance. The HOPE initiative enables Oregon to continue to be a model for the rest of the nation, and we should rise to this opportunity. Providing individuals with access to affordable health care is the right thing to do, both from a financial and ethical standpoint. Thank you for your time.
Chair Greenlick and members of the committee, my name is Mark Thompson, and I want to thank you for this opportunity to speak in support of the HOPE initiative as a small business owner in Beaverton. I founded my company, Forefront Economics, 25 years ago to provide economic analysis to energy utilities. After 25 years of navigating the market for healthcare insurance, I'm convinced that recognizing the fundamental importance of access to affordable healthcare for all Oregonians is critical to the economic health and prosperity of our state. It's important that small businesses are shielded from the vagaries of cost imposed by the uninsured. It's also, when the state recognizes the importance of access to affordable care for all of its citizens, the healthcare insurance markets operate more cost-effectively for everyone, including small business owners. Our cost of healthcare insurance has surged faster than any other cost in our budget. A stable market for healthcare, where costs are rising at predictable and reasonable rates, are important for a positive business environment. That is one reason that I urge you to support HJR 203. I'd like to also address the importance of HJR 203, the HOPE initiative, would have on the entrepreneurial spirit of our great state. Before I decided to leave a job with excellent health care benefits and start my own company, I wrestled with imposing that risk on my wife and 2 young children, the risk of an expensive and uncertain health care future. On a star-filled summer night in eastern Oregon, after backpacking with my family in the Wallowas, and with my wife's encouragement, I finally decided to take that risk. Today, I can't help but wonder how many young entrepreneurs don't make the leap because of the risk associated with health care. Passing H.R. 203 would send the message that Oregon cares and has the backs of Oregon families by recognizing the fundamental importance of access to health care. I'm convinced that doing so would contribute to a better entrepreneurial and overall business environment for our great state. The HOPE initiative guarantees that Oregon continues moving forward to achieve health care coverage instead of and continuing to have health care coverage not dependent on your wealth or who you happen to work for. And
And instead of shifting costs to small businesses or people that are already struggling to pay their bills, it's time we continue to advance and expand health care, not go back, which is why I urge your support for HJR 203. Thank you for your time.
Chair Greenlick and members of the committee, I'm Charlie Swanson. I'm here today representing 27,000 members of Healthcare for All Oregon in support of HJR 203, the Hope Amendment. Advocates with Healthcare for All Oregon support this initiative so that we have the opportunity to affirm what voters have continually told us. Healthcare is a right. No Oregonian should have to choose between paying for necessary health care or paying the expenses of daily living. I'm also an advocate member of the Universal Access to Health Care Work Group chaired by Representative Salinas. As stated in its charter, the work group will do its best to come up with, and I'll quote, a roadmap to creating a system of universal and affordable health care for all Oregon residents, one which would promote choice of providers, transparency, and accountability, and would improve the health of Oregonians. The Hope Amendment will simply add the shared belief in the right of access to affordable health care to our state constitution. The work group will bring together some bright minds in health care so that we can move forward together. The Hope Amendment ensures that we continue to move forward with health care transformation and not go back. Thank you for the opportunity to testify in support of HJR 203 today to ensure affordable access, to ensure that access to affordable health care is a fundamental right in Oregon.
Any questions in this panel? Should you call the next panel? Would you call the next panel, please?
And we have Carol Ann Fry.
Just one person? Wow. Hello, I'm Carol Ann Fry. Rob is my district leader, so hi, Rob. Or not district leader, excuse me, my representative, sorry. I wasn't actually planning to say anything today. This is my first time really kind of being to the Capitol, so hello, everyone. I didn't plan on saying anything today, but the fact that it is February 7th is much too serendipitous of a date to pass up for me. 3 years ago today, February 7th, what would have been my mom's 50th birthday, and it was also her funeral. She was the working poor. She was too poor to be able to afford health insurance. By the time she was found unconscious on the floor and sick enough to finally be able to go see a doctor, her cancer was already terminal. The doctor gave her 8 months to live, and that was a very accurate statement. Before those 8 months, I could tell you all about how she self-diagnosed her insulin and didn't take her thyroid medicine because she couldn't afford to go to a doctor to get the prescriptions, let alone being able to afford the prescriptions. But you have all heard many stories like that of people not being able to afford health care. I'm not here to talk about policy. I'm not a policy wonk. I just merely wanted to say that a statement such as this in our Constitution is so fitting of our wonderful state and of the time. We're the richest country in the world ever in the history, and to not be able to give our own citizens, whether they work hard, whether they're citizens of the U.S., whether they have the proper paperwork, to not be able to afford to give them health care is criminal. And this isn't even going into that. This is just merely putting the language in our Constitution, naming that healthcare is a fundamental right to being a person who lives on this planet. So again, as I said, I'm not a policy wonk. I know earlier you were getting into the weeds about what this means down the road. This is not down the road. This is right now. This is to people like me and people to my mom. My grandma's birthday is a couple weeks after my mom's, and so today when we celebrate her funeral and her life, 2 weeks from now we have my grandma's birthday, and my grandma doesn't have a daughter because my mom couldn't afford health insurance. I mean, how sad is that to have to look at my grandma's really sad face on her birthday when my mom isn't there to celebrate with her. So anyway, I just really want to thank you for your time, and I really appreciate the work that both of you are doing to bring this to the forefront of our state and national conversation. So thank you all.
You have a big job taking your mom's place with your grandma.
Yeah, that's exactly what I was going to say.
Is there anybody we've missed who'd like to testify?
Nope. One more.
This is on the cuff, so I'm just going to talk. It's very short.
Yeah.
When I was working at, my name's Don Klosterman. I'm from Wilsonville. When I was volunteering full-time at Medical Teams International, I was helping them raise money for a big a building. And we had a consultant, and so I asked him, you know, how is it that you can go ask money from people? Isn't that hard? And he said, no. He said, it's easy. What I'm doing is I'm helping people get the joy of sharing. And it stuck with me for a long, long time. A second story is when they have dental vans. And there was a story of about a 8-year-old boy down in Salem at one of the elementary schools in North Salem. And the little boy kept missing school, and he had all this pus and stuff, green stuff coming out of his nose, and so he was always home. So what they did is the dental van fixed that, and what happened is his attendance went right up, stayed high, his grades improved, and so forth. And so if you're talking about educational attainment, if you're talking about have a good job and so forth down the road, that's one. The last one that I heard was volunteer dentist told us about a time he was out in Eastern Oregon. And he said that, you know, I helped a gentleman who was probably in his 70s, who really didn't have anything and all his teeth were really rotten. And he said they took the teeth out and they helped him. And the guy came back and he said, you know, you'll never know how many nights I did not sleep. And so I'm asking you, if there are taxes down the road, that you help people to share and have the joy that comes from that you would be helping people like these. Thank you.
Thank you very much. I'm going to close public hearing.
There's somebody else.
Wait, there's one more standing up, sorry.
I'm sorry.
Do you want to hear from some more?
Sure.
Right, yeah.
We've got 3 people now.
Yep.
Come on
up.
Yep.
Please, yeah. For those that stood up want to testify, please, we'll have a panel. Anyone else? Please, come on up.
Okay.
Go for it.
Chair Greenlake and members of the committee, thanks again for the opportunity to testify, this time in support of HDAR 203. My name is Michael Huntington, a retired radiation oncologist from Corvallis, and I am supporting HDAR 203 because I feel strongly that people should not have to forego the care they need because they fear health care costs. I saw this happen repeatedly at the Cancer Center in Corvallis, where I worked for 22 years. Patients would come through the emergency room in crisis because of neglected cancer. Many patients had to make tragic choices once they came into the Cancer Center. One patient was a middle-aged man with children who was overheard at our Cancer Center telling his wife that he was going to decline treatment for his lung cancer because he did not want to leave her and the children bankrupt and homeless. Others didn't get the chance to make those choices. Tracy McEwen, who testified before you last year, you may remember him, had been excluded from health care because of income, had undiagnosed hypertension, and then a devastating stroke that not only cost him and his family undue suffering, but cost Medicaid and Medicare, which he now qualified for, with bills of over $400,000 in the past 5 years. Another middle-aged businessman who had hypertensive stroke was not as fortunate. After many years in a nursing home, he died and did leave his family bankrupt. I know of a roofer who whose only thought during the fall from the roof was, I hope this kills me. I'm sure that every doctor in Oregon can give you equally tragic stories, some of which are developing as I speak. Many of these compelling stories are posted on Healthcare for All Oregon website, hcao.org, under the Resources tab. I encourage you to support the Hope Amendment. It is a logical step to prevent unnecessary suffering and cost for Oregonians. Thank you.
Thank you,
Chair Greenlick and members of the committee, thank you for the opportunity to testify in support of HJR 203 and to affirm affordable health care as a human right. My name is Trevor Phillips. I am a board-certified emergency room physician, and I have the privilege of working with a team of real-life superheroes in the Salem Hospital Emergency Department for the past 10 years. I support House Joint Resolution 203 because it will save lives, and it is the right thing to do. Emergency departments across our state and across our country are seeing unprecedented increases in patient volumes year after year after year. I can testify today that while we provide the best rescue care on earth, there are times when rescue care is not enough. We as Oregonians must ensure access to affordable preventive care, such as routine checkups and tests for chronic illness. By doing so, we will ultimately improve the health and well-being of all Oregonians. Ensuring access to affordable, routine care will save lives. I'm a second-generation Oregonian. I grew up in Josephine County, and I've lived in Oregon for over 25 years. I've seen our state grow and take the lead on many healthcare issues. We remain at the forefront of innovative healthcare delivery. Right now, history calls upon us as Oregonians to lead with our values once again. The Hope Amendment simply enshrines into the state constitution a shared value of Oregonians. Everyone should have accessible, affordable health care. Recent election results and public polling show that a strong majority of Oregonians and Americans believe that health care is a human right. Our state has served as a national leader by ensuring that 95% of Oregonians have health care coverage. We can never go back to a time when health care was only for the healthy and wealthy. House Joint Resolution 203 is an incredibly important step in finding solutions to make sure that 100% of Oregonians can afford, utilize, and benefit from the comprehensive care that they need and deserve. Again, I support HJR 203 because it will save lives. It is the right thing to do. On behalf of my family, friends, and patients, I emphatically encourage you to support the Hope Amendment today. Thank you for your time and consideration.
Thank you. Got to end on an upbeat note.
Yep, okay, I will. My name's Chris Lowe. I live in Portland. I've been an advocate for universal publicly funded health care, single-payer health care for over 10 years now in Oregon. And I want to just make two brief points. One is to address the concern that Representative Vial raised about the potential of competition between funding for healthcare and funding for other prior education or anything else. We have the least efficient healthcare system in the world, the industrialized world, and moving to well-organized universal care, whether it's single payer or a model like the German model, which is not exactly single payer, but it's universal and well-organized and doesn't depend on employment, we're actually going to save money to society, to the state budget, to all the local budgets. There'll be more money to fund education, not less, if we move towards that. But the main point I want to make here is about the idea of hope in the idea of the Hope Amendment. Because in my 10 years of advocacy about this, I've taken a deep dive into all of the different literature. I studied public health up at OHSU in a department that Representative Greenlick helped organize many years ago. And what's come to stand out for me is not just saving lives, but the extent to which Americans and Oregonians live under burdens of fear. Whether, so there's the inhumanity of worrying about, bankrupting your family. There's inhumanity for the family members of having to worry about how they're going to pay for things when they should just be having to focus on helping a loved one get healed. There is the fear of leaving a bad job because you might not be able to have as good health insurance. There's the fear that was referred to about, not taking up an entrepreneurial opportunity. I think there's tremendous energy in Oregon that will be unleashed. There's hope here that comes from the idea of universal care. And so, the term in OHSU, we would have talked about morbidity as well as mortality. Morbidity is all the ways that ill health limits you in one. It might be productivity, it might be depression, it might be any number of kinds of things that come out of fear and hopelessness. So I support the Hope Amendment and see it as hopeful because it sets up the conditions for the right kind of debate about what's the way forward. Thanks.
Thank you very much. Close the public hearing on HJR 203 and open up a work session on HJR 203.
Chair Greenlick, I would like to move that the committee adopt -1 amendments dated February 7th, 2018.
Those moves, we adopt the -1 amendments dated 2/7/18. That amendment changes one word. It changes the word effective to the word cost effective, which is what we actually think about medical care now. And
it's a hyphenated word.
Is there any discussion on the amendment?
Representative Vile. No? Okay.
Any objection to the amendment?
No.
So moved.
Chair Greenlick, I would like to move HJR 203 as amended to the floor with a due pass recommendation and that the subsequent referral to the House Committee on Rules be rescinded.
Representative Noce moves HJR 203 as amended to the floor with a due pass recommendation and that the subsequent referral to the Rules Committee be rescinded. Discussion. And Kenny Geyer, did you have?
If you offer me the opportunity, I'd love to. I didn't have my hand out, but I strongly support this, and I think a lot about the comparison of this and education and how we as a state and a country have said that every kid has the right to a K through 12 education. And I don't understand why this would be any different. We know that that's what creates a strong society, and I firmly believe that every single person should also have the right to affordable, cost-effective health care. I agree, even in the education realm, although it's a right, we have a lot of debates about what the quality of that is. And so there's a lot of room for that kind of discussion, and I'm honored to be on this committee to continue to have that discussion. But I think we need to have the same kind of fundamental right and understanding about healthcare as we do toward education. So I'm strongly in support.
Thank you. Mr. Vile?
Thank you, Chair Greenlick. This is sobering. It is clear that the things I have learned in the last few months, and even just sitting here today, have changed my view on a number of things, including the concept of universal health care and how we treat one another as a society. I want to tell the last gentleman how much I appreciate your comments tonight. But I'm not able to support this at this time, and for some of the same reasons that we've talked about. We do have a constitutional right to education in this country, and yet more every year litigation continues to eat at that. And the reality is that we do not have a good education system in this country in spite of that constitutional right. And Oregon particularly has found itself without being successful in educating our children, and almost to the point that we're getting less successful all the time. I do not for one moment believe that we do have an efficient healthcare delivery system in this country. It's horrible. I was sitting here looking at the difference between Canada and the U.S. because I always hear about, well, you can't get anything done in Canada. But the reality is in Canada, mortality rates are better, fertility rates are better, child mortality rates are much better. There's all kinds of things that are much, much better in that system. And I know that we have to do better here, but I fear that by making it a constitutional right in Oregon, we then put a demand on the system that will not allow us to really structure it in a way that makes it better, instead only invites the arguments that we are having even around education today. Again, Mr. Chairman, you have given me a wonderful opportunity to rethink a lot of the basic things that I have thought about this concept for many years, and I'm grateful for that. But I'm sorry that I can't support the amendment at this time.
I predict you'll get there. Representative Salinas.
I'll take that as a
Hopefully by November.
That's right. We'll talk before you fill out your ballot.
Thank you, Chair Greenlick, and thank you, Representative Vial. I actually am so thrilled that you are serving on the Universal Access to Care Work Group because, like Representative Greenlick, I think we're going to get there, and you're going to be the one to tell us what the hard trade-offs are as we march towards some solutions and options for 2019. So thank you for your comments, and I appreciate them. And yeah, I have the same, I think we all have the same concerns, but I think what this says, this resolution today basically says that this is not only the political will of the legislature, but we're passing it on to make sure that this is the political will of the people. And that really excites me. Thank you.
Representative.
We got
Okay.
Representative Melser.
I'll just make it really simple. I think that at my absolute core, I believe this is what the majority of Oregonians believe, and I think it should simply be in our Constitution.
Thank you. Representative Alonso Leon.
Thank you, Chair. Yeah, simply put, having the language in our Constitution equals everybody having the right to health care, equals them having an opportunity for an education, which then will strengthen our economy and our state. While we cannot control what the feds are doing in respect to our healthcare system, we have this amazing opportunity in the state of Oregon to make that change. Thank you all who came to present and give your perspectives. But I am really excited about this extraordinary opportunity and am looking forward to continuing to support and fight the fight.
Representative Nose.
So maybe people in the audience know or don't know, a lot of us legislators, this is considered a part-time job. And so some of us still, have to work while we're doing this. And some of you probably know I'm a longtime union organizer. And I want to say I'm very proud of my own union, the Oregon Nurses Association, where I have the privilege to work, for stepping up and being willing to lead on this. And it really warms my heart to be able to be here in this room with my union and to be able to be a part of this. And I also want to say how I'm really glad that Healthcare for All Oregon formed, and the organizing that you all are doing in this state is so important and very amazing. The labor movement isn't going to be able to do this all on its own, and I know the labor movement participates a lot in your organization, as do small business, as do a lot of other faith groups and other community-based organizations in this state, but it takes organization as well as political will to make something happen, and I appreciate all of you banding together to come forward and help us try to get this across the finish line.
Anybody else? Will you call the roll, please?
Representative Salinas? Aye. Representative Vial?
No.
Representative Malmström?
Aye.
Representative Kennemer?
Excuse.
Representative Kenny Dyer?
Aye.
Representative Bueller?
Excuse.
Representative Alonzo Leon?
Yes.
Representative Bowles?
Nay.
Vice Chair Nos?
Yes.
Vice Chair Hayden?
No.
Chair Greenlick?
Yes. Motion carries. HJR 203 is on its way to the floor. I'll be pleased to carry it.
I bet you will.
How does it go?
It was a work session on HJR 203. Before we adjourn, I want to review the bills we carried over to Monday.
Committee.
4005, 4137, sorry, 4156, 4135, 4018.
So carried over to Monday?
I'm
Friday.
sorry,
Friday.
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 Okay, 8 a.m.
8 a.m.?
8 a.m. Friday.
Are you driving home? Yes.
Friday at 8 a.m.